I think you can start.
Okay, okay. Thank you. Yeah. Nilima, will you give me a count of 3 or something? Or should I
Yes,
start
ma'am.
like?
Yeah, yeah.
Well, give
Yes,
me a
we'll
count.
all mute and you give the count.
Give a count, Nilim.
Yes, ma'am. One,
Okay.
2, 3. Ma'am, go
Yeah.
ahead. Go ahead.
Yeah. Thank you so much. It's an honor to meet all of you today. This is going to be the ICOG certificate course on medical disorders in pregnancy. Will be there for 3 days. Today will be the first day, 25th, 26th, and 27th. The first day will be covering hypertensive disorders. The second day will be on hyperglycemia in pregnancy, and the third day will be on the miscellaneous causes, and that will be SLE, APLA, and other causes which are causing havoc during obstetric management. So it's an honor to invite I'm sorry, I should not say invite. I want to welcome the ICOG chair, Dr. Parag Biniwale, the vice chairpersons, and our dear secretary, Dr. Sarita Bellarao, as well as all the other faculty have joined, as well our conveners for tomorrow and day after tomorrow, Dr. Komal Chavan, as well as Dr. Achla Batra. The coordinators for all the 3 days, Dr. Neha, Dr. Jayanani Kamaraj, as well as Dr. Monica Singh. And I would like to thank all the delegates who have joined today, and we want to welcome you to this program. We have made the program in such a way that there is some time for interaction, but we request that you put the questions in the chat box so that the faculty can answer the questions, and if there's time, they will answer through the webinar. But please put your questions in the chat box so that there's good interaction and everybody gets home with some take-home messages. Can I have the next slide, Nilima? Now we'd like to start the inauguration of the certificate course, and I request Nilima to play the inaugural song.
Kurutvam kalyanam arogyam dhanasampadah Shubham kurutvam kalyanam arogyam dhanasampadah Shatrubuddhi vinashaya Deepajyotir namostute Deepajyotir namostute Shubham kurutvam kalyanam आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
Thank you so much, Nilima. Can I have the next slide, please? And we want to welcome the president of FOXI, Dr. Sunita Tandulwadkar, the chairperson, Dr. Parag Biniwale, and the secretary, Dr. Sarita Bellarao. Dr. Parag has joined today. Can I have Dr. Parag's slide, please, Nilima? Dr. Parag does not need any introduction to any society in FOXI. He's a person who gives room for people to work and always is a source of encouragement. He's a senior consultant from Pune, and he's also a PG teacher, unit head at Kamala Nehru Hospital.
Don't waste time.
And he's the president of the Indian College of Obstetrics and Gynecology 2025. Can we have a few words from you, Parag, before we start the program?
Thank you, Charmila. Good evening. I bring greetings from ICOG, and it's indeed a pleasure to welcome you all on behalf of all the office bearers for the 3-day certificate course on medical disorders in pregnancy. At the outset, let me compliment the team who has put in a lot of efforts, our conveners, Dr. Charmila, Dr. Komal Chavan, and Dr. Achla Batra, ably assisted by our coordinators, Dr. Monica Singh, Dr. Jayarani Kamraj, and Dr. Neha Tandon. Tremendous work, because putting together the program, getting in touch with the faculty, and of course asking them to give questions for the post-it is a big task. When we were discussing how to formulate this program, we thought we have to give due importance to 2 medical conditions which are so important to us. One of them being hypertensive disorders of pregnancy, and the second hyperglycemia in pregnancy. So we decided to dedicate 1 day full to these 2 conditions, and of course on the 3rd day we'll have rest of the conditions which are important but not as commonly seen as HDP and HIP. So it's going to be an exhaustive learning for all of us. So I'm looking forward to some interesting sessions and discussions. So thank you once again. On behalf of ICOG, I welcome you all, and happy learning to everyone. Thank you.
Thank you, Parag. Thank you so much. Can I have the CV of Dr. Sarita, please? Dr. Sarita is a consultant obstetrician gynecologist from Mumbai, and she's a secretary of the Indian College. and she's been the immediate past chair of the ICSE RCOG West Zone. Can we have a few words from Dr. Sarita before we start the program?
Yeah, thank you, Dr. Charmila. And I think Dr. Parag has really said it all. I really congratulate you and Dr. Achla and Dr. Komal Chavan for the fantastic work that you've done in putting together this course. And I'm really happy that these certificate courses are so popular and getting more and more registrations every time. I'd also like to remind everybody that it is our online fellowship program. It is open. The next convocation will be in Delhi at the AICOG, and the date is 30th of September. So please do get your points together and apply so that you can do that. And we have a packed month in July. So I invite everybody to check on the ICOG website for the July program. Best of luck for this program. I'm sure it's going to be a fantastic learning for 3 days.
Thank you, Sarita. Thank you so much. Nilima, the next slide, please. So that there are some instructions for the participants if you want to get the ICOG online certificate on this program, Medical Disorders in Pregnancy. The attendance for all the 3 days course is compulsory. There will be a Google link which will be put for the MCQs in the chat box at the end of the program, and that will be around 7 o'clock every day for the next 3 days. And you have to attend all the 3 days course and pass with 50% marks on each day, and then you will be eligible for a certificate from ICOG. The certificate will be issued within 1 month, and it's just an acknowledgement of attendance. Actually, the practice will depend on skill and experience, which we do not certify. So we request that you attend on all the 3 days, and please get your certificate of attendance as well as for the assessment. And in future, the videos will be put on the ICOG website so that you can go through the program again. Thank you so much for joining. I think we've got almost 1,000 registrations for this program, and it's an honor to have all of you with us. I am the convener for today. Next slide. The convener for the day 2 is Dr. Komal Chavan. She's a vice president of FOXI 2025, and she's held several important positions in FOXI and ICOG, and she's won several awards. She's got several papers to her credit also. Can I have the next slide, please? Dr. Achla Madam will be the convener for day 3. She is a national president of NARCHI 22-24. She's also the governing council member of ICOG. She is a professor at VMCC Safdarjung Hospital with an experience of almost 40 years. She's got several papers to her credit. The next slide, please. Yeah, the coordinators for today. I'm extremely thankful to Dr. Neha Pruthi Tandon, who has put up a fantastic job to get this program into place. She's a coordinator for today. She's an associate professor at ABVMS and Dr. RML Hospital, Delhi. Welcome, Neha. Can I have the next slide? And then the coordinator for day 2 will be Dr. Jayarani Kamaraj. She's a associate secretary of the World Association of Sexual Health. She's been the vice president of TAPISAR and the joint secretary of TNFOG, and she has won several awards and has got several medals also. Next. Dr. Monica Jindal Singh will be the coordinator for day 3, and she's from Bhopal, and she holds several positions both in FOXI societies as well as in other organizations. And all the 3 coordinators are fantastic workers who have done so much of help for us. We are thankful to all 3 of them. So the program for today will be on hypertensive disorders in pregnancy. And we have got good speakers. We have not touched upon topics which are common, but we have taken up topics which have got lots of clinical importance, because many times we have got so much of queries when you want to manage this dreaded disease, and still it contributes to a big chunk of morbidity and mortality in mothers. So please listen to all the faculty. We were all great speakers, and we're extremely thankful for them for sparing the valuable time and giving their inputs for this workshop. Thank you so much. We'll go on to the academic session. May I request Dr. Neha to take over the program, please?
Yes. Good afternoon, everyone. I would like to invite the speakers for the first session. Dr. Asha Rao, Madam is Director, Rao Hospital Care Coimbatore, Director for Postdoctorate Fellowship Program in Reproductive Medicine and Endogynecology. She has many publications to her credit. Welcome, ma'am. Next slide. Next, I would like to invite Dr. Bharti Maheshwari, Professor. Madam is Professor and Head of Department, Muzaffarnagar Medical College. Madam has done diploma in IVF and Reproductive Medicine from Germany. She has organized many conferences and has delivered Kamini Rao orations and many talks in national and international conferences. Welcome, ma'am. I would request the chairpersons to please introduce the speakers and start the session.
Thank you, Dr. Neha. It's such an honor to be here today as a chairperson. And the first topic of the day is utility of aspirin. Aspirin has been a wonder drug and utilized for very many conditions and widely used in pregnancy. And today we have Dr. Gorak Mandrupkar as a speaker. He's a consultant in reproductive medicine, Mandrupkar Clinic, Islampur, post-graduation OBGYN clinical research, medical legal system, Vice President, Gestosis India Association. And I request Dr. Gorak to deliver this talk on utility of aspirin.
Am I audible and visible?
Yes. Yes, you are.
Yes, Gorak,
Yes.
you are audible. Yes.
Right. So, good evening, all of you. And I'm very much thankful to ICOG office bearers, Dr. Parag Biniwale, sir, Chief, and Dr. Charmila Ayau, who actually invited me for this. And she has purposefully selected the topics and the persons, I think. Because, yes, there are, as she mentioned in her talk, that there are so many confusions. There are so many things which are going on the research level that one as a practitioner may get confusion kya what to write and what is the current guideline says. So thank you very much, and I'm thankful to Dr. Neha as well for always keeping behind.
Gorak, 1 second. Dr. Swarna madam is joined. I'll just invite her 1 second. Madam, can you stop sharing 1 second? Yeah. Dr. Swarna madam? Dr. Swarna has joined. Neelima?
Yes, ma'am.
Can I have Dr. Swarna Kadilkar is the Secretary General of FOXI, and we're extremely honored to have her in the program. Ma'am, can you say a few words before we start the program? Swarna madam? Swarna ma'am?
Yes.
Yeah.
Am I audible now? Because there is some
Yes,
issue
ma'am.
in my
So, you're audible, madam. Yes, ma'am.
yeah. Okay. Good evening, everyone. And this medical disorders in pregnancy is a very, very important topic. And I just learned that Charmila has been on the forefront along with ICOG chair, Dr. Parag and Sarita. So I'm sure this will be a great hit, the whole course for 3 days. And I wish you all the best for this course. And I think Gorak, and there are so many experts in the, all of you are working together on another, society which is focusing on the PIH or the Gestosis Society. And you all are doing good work in the field of preeclampsia, eclampsia. And we are going to also discuss so many other medical disorders over 3 days. And I can see a good attendance of 299. And it's a huge kind of attendance for a program. And I always appreciate and admire the hard work put in by the entire team to get this kind of audience for these courses. So I wish all of you all the best for this. And I'm sure at the end of 3 days, you will go back with much great knowledge in the field of medical disorders in pregnancy. And thank you so much for inviting me here.
Thank you so much, ma'am. It's an honor to have you here. And Gorak, I'm sorry for the interruption. You can start now. Thank you. You have to unmute yourself.
Now, okay?
Yes, fine.
Right. So we will start the today's topic, and the topic is aspirin, the utility, and that too mainly in the context of hypertensive disorders of the pregnancy. Everybody of know that now initially it was a preeclamptic toxemia. It was a toxemia of the pregnancy. Then it became pregnancy-induced hypertension. Then it became preeclampsia, eclampsia syndrome. And now it has become as a hypertensive disorders of the pregnancy. We know that still, whatever may be the reason, whatever modern facilities we may provide to the women, or we take the deliveries from home to hospital, still, even in modern hospitals, the incidence of preeclampsia is still 10.3%, especially in India. When we consider the maternal mortality, it is still quoted by WHO in 2024 as 19%. And if we consider our Indian population, then there are certain pockets, there are certain states, and I am now working with Karnataka. So I will specially mention that there are certain districts in Karnataka, in Maharashtra, in Uttar Pradesh, in many parts of the northern India, where the incidence is too high. And then when we consider, initially it was that the secondary prevention, ki baba, in known cases of hypertensive disorders of pregnancy or in known cases of preeclampsia, aspirin will save us along with calcium. That was the dictum. But now the hopes are increased and we are looking towards the aspirin as a drug of primary prevention as such. And then, as we know, the next topic is on prediction. There, madam will be mentioning all the possible prediction tests, right from clinical risk assessment to the newer test. But when we do the prediction or when we do the universal screening, what is in our hand, that main Brahmastra is aspirin. Actually, the references of aspirin, they are seen so many years in history, but if we see the main features, in 1829, the French pharmacist Pierre Joseph obtained crystals of salicin after boiling the powdered bark of white willow. In 42, again, Raphael Peary performed the first synthesis of salicylic acid. 1953 means almost 100 years after. Charles Gerhardt was the first to isolate the acetyl salicylic acid. John Wayne discovered the mechanism of action, and then he won the prize of Nobel Prize in the Physiology of Medicine in 1982. And almost after the discovery of the acetyl salicylic acid as such, after almost 160 years after, Bufils first time suggested that it can be used in the prevention of preeclampsia. And then today, whatever I'm going to present in front of you is the journey from 1985 till 2025. Means, to be frank, to be precise, it's a journey of only 40 years. And in 40 years, certain concepts are totally been changed. Daily they are changing, and how we are going to see. The first and foremost thing, during these coming 10 minutes, I am going to focus only on the facts which are based by the good clinical evidences, that too from recommendations, and that too from the good researchers. Now the concept is very clear about the mechanism of action of the aspirin. Before that, we must understand that there is something called as thromboxane A2. And this thromboxane A2 is produced by the platelets and by the placenta, especially as a response to the hypoxia. Again, this thromboxane A2 is responsible for vasoconstriction, induction of vascular remodeling, increasing platelet aggregation, as well as adhesion. That means we know the Vollard theory that because of the wave of the vasospasm, there is a cascade of reactions which is going on inside the body. It is again because of the defective trophoblastic invasion. We know the model of how the trophoblast, they cause a problem, how the spiral arterioles. I'm not going in details because that is not my today's topic, but we know that. Another things are there, they are prostacyclins, and prostacyclins are vasodilatory mediators, and they inhibit the vascular remodeling, platelet aggregation, and platelet adhesion. So once we understand this, then this aspirin inhibits thromboxane A2 production by the platelets. So whatever happens, because of the defective trophoblastic invasion, because of the vasospastic wave, because of the inflammatory reaction at the molecular level and at the cellular level, it is the release of thromboxane A2, and aspirin inhibits thromboxane A2. Again, there is a balance always in the body of the thromboxane A2 and PGI2. So vasoconstrictors and vasodilators both are required by the body, and a perfect balance is always maintained. And then if there is an imbalance, that is when thromboxane A2 increases, PGI2 decreases, it is the imbalance. And this imbalance can be reversed by just 2 weeks of treatment of low dose aspirin. It inhibits thromboxane A2 secretion, thus platelet aggregation, without altering secretion of PGI2, thereby favoring systemic vasodilatation. So that is the first beneficial effect we have to understand at cellular level. Also, it decreases production of tissue factor thrombin. Another mechanism of action we must understand that due to the stimulation or due to the hypoxia, due to the inflammation, there is another thing which comes out in the body, and that is SFLT1. That is a soluble form of VEGF receptor, which is in binding to circulating PLGF and VEGF. It behaves as a potent anti-angiogenic factor. Again, it is a bad thing. And it has been found that SFLT1 is present at high levels in the circulation of patients with preeclampsia. So again, it is responsible for the angiogenic imbalance. First we saw that, and another, this is a second thing, this is an angiogenic imbalance. And in hypoxic condition, aspirin inhibits the expression of SFLT1 in human trophoblast. And that means, again, it is proactive for pro-angiogenic activity. So by these two mechanisms, aspirin beyond doubt is going to prevent preeclampsia. So that's very clear. Now, what is the effectivity? After the first paper of 1985, then in 1991, first paper, this is the first paper which was with Imperial and Petroulis, and they showed that low dose aspirin reduces the risk. Then they were using the word of PIH, now we say HDP, by 65%. And it significantly lowers the incidence of severe low birth weight and preterm birth, because those were the secondary outcomes of their study. Again, if we see the recent paper 2017 by Rolinick, that is a group which works with Levonapool and all that group of aspirin. In his paper, he says that low dose aspirin reduces the risk of HDP by 78%. And if we see the very recent paper 2025 of Sibayan group, they say that with low dose aspirin, even they have gone beyond 78%. So this is the effectivity. So beyond doubt, we have to start aspirin low dose to prevent preeclampsia in at-risk patients. Now, what is low dose aspirin? 50 low dose, 60 low dose, 75, 81, 100, 150, 162. So whatever less than 300 is called as low dose aspirin. Again, like what we show the other hormone levels, one day I was uttering, the normal level of testosterone, you say 10 as a normal, 72 as also normal. So like that, low dose aspirin, 50 is also low and less than 300 is also low. So many things they were tried. And then what are the facts then? Then what should we choose? So that is a confusion because so many guidelines are giving different guidelines and they are saying ki ye dose use karo. So that's why here comes the facts. Sibahi, Baha M. Sibahi, the person who has more than 100 national and international papers and the maximum research and on whose research all guidelines almost are they are depicted, he has reported only 60 to 80 milligram of the aspirin a day reduced thromboxane A2 production in over 90% of the pregnant women after few days of treatment. In his paper, he has mentioned more than 2 weeks. So that means it is the 60 to 80 milligram of the aspirin. It is documented. Second paper came by Roberts, and Roberts says, no, it's only 50 milligram. So it noted that 50 milligram the aspirin a day reduced thromboxane A2 production in over 95% of the cases without altering prostacyclin production. So that means we have to have the balance because again there is a concept in the aspirin that as dose of the aspirin increases, it will inhibit prostacyclin also. So that is a problem. Here what we want to reduce the thromboxane A2. We want the inhibition of thromboxane A2. We do not want the inhibition of prostacyclin. And this fact was again depicted by these two researchers that 100 to 300 milligram of the aspirin per day completely inhibited thromboxane A2 production and also inhibited prostacyclin. So that's why the researchers are very much in confusion whether to increase the dose or not. And again in 2017, Atalla has done a very beautiful analysis very recently and has shown that yes, low dose aspirin has a good maternal fetal safety profile. Clear. So it has to be used. But the number of patients who are exposed to doses over 100 milligram is low and safety of prevention strategy based on 150 milligram per day has to be confirmed. So what should be the dose? So safety aspirin 75 milligram is easily available, used since decades. So aspirin 75 milligram at bedtime, daily, till 2 days prior induction or delivery is the best option to prevent preeclampsia. Now, why at bedtime? Because a randomized trial in Spain has showed that a beneficial effect on diurnal blood pressure, reduction of obstetric effect was when it was used in evening or at bedtime. Again, Bonten has showed the same thing. It's very now clear that low doses of aspirin are effective in secondary prevention in those with history of preeclampsia, but now WHO, RCOG, ACOG, our own FOXI, ICOG, now we are suggesting the role of aspirin in the primary prevention. So as soon as we do the screening of a pregnant women, either by method, we are recommending it is HDP justosis score, but by any method, we should start aspirin. And again, there is another, I think this is the last slide. There is a beautiful concept that it is not the dose of the aspirin, but it is the timing of initiation of the aspirin that matters a lot. Initially, everybody suggested at 20 weeks, then they came down at 16 weeks, now they came down at less than 12 weeks, but we are recommending as soon as possible after the cardiac activity is appreciated. When you screen the patient and find that he is at risk to develop preeclampsia, we have to start aspirin 75 milligram at bedtime. Last slide. Can we achieve eclampsia Mukt Bharat? We can achieve by using this aspirin 75 milligram at bedtime along with other factors. And this is the thing, why still we are saying that only aspirin will reduce the incidence of preeclampsia by 65 to 78%. Remaining, if we want to achieve universal screening by Justosi score, low carbohydrates, calcium 1 gram, effective antihypertensive at 140/90, Maxel for all severe HDPs, and early referral, it is going to give us the Glycamagar approach, the Eclampsia Mukt Bharat. In This is a Future Role, very recent paper in 2025 showing that safety of daily low dose aspirin during pregnancy in low income and middle income countries in the prevention of preterm labor. This study was conducted in Pakistan, 2 centers at India, 4 countries in Africa, and they have shown that it's a very, very recent paper conducted on more than 12,000 people, and it shows that yes, apart from preeclampsia, apart from prevention of cardiovascular events, for the prevention of preterm labor, aspirin 75 milligram at bedtime right from first trimester is the effective treatment. Thank you very much for patient listening and for extra 1 minute. Over to you.
Yeah.
Thank you
That's
so
an
much, sir,
excellent talk,
and for being
Dr.
very precise and crisp.
Parag.
Ma'am, Asha ma'am wants to say something.
Oh, no, I said that's an excellent talk with a lot of clarity. And there was a question coming up about the role of 150 milligram of aspirin.
Madam, we'll have the discussion in the chat box at the
Later.
end of the session.
Fine,
Yes,
fine. Okay.
Just can I have only one line?
yes, madam.
The one line is that there is no single paper who has compared 75 milligram with 150 milligram. And that's why the paper which has come from only one FIGO guideline and the fetal medicine guideline, they have compared aspirin with placebo. And that's why WHO has intervened and WHO has put the white paper in 2024 saying that till further research clarifies 75 milligram at bedtime right from first trimester till 2 days prior delivery or labor induction, and FOXY ICOG has endorsed, along with Justosis India, has endorsed this guideline. Thank you very much.
That's why we wanted to start with the controversy so that the program will go on well. And Gorak is one of the apt people to talk on such an important topic. Thank you, Gorak. Thank you so much. Please answer the questions in the chat box. There are many people who are asking questions. Thank you. Nega,
Ma'am, I would request Asha ma'am to please invite the second speaker.
Bharati has not joined?
Ma'am hasn't joined.
Okay.
It gives me
Asha.
great pleasure to invite Dr. Aparna Sharma. She has done a master's in maternal fetal medicine from Barcelona University. She's a professor of ONG AIMS New Delhi, fetal medicine specialist with expertise in fetal interventions, secretary of the Society of Fetal Medicine 2022 to 24, chairperson multiple pregnancy committees, Silver Society of India. She has done a lot of work. She was also the orator for Kamindira Orator 2017. And I invite Dr. Aparna Sharma to deliver her talk.
Hi everyone, very good evening. Thank you, Dr. Charmila and the team ICO. Am I audible?
Yeah, you're audible.
Yes, we can hear you.
Yes.
Yeah, thank you for having me here today. So I'll be just, can you see my screen? Yeah, that's fine. I hope my screen is now visible.
No, not yet. Yeah, now it's coming. Aparna, it's coming.
Yeah.
Yeah, it's there.
So I'm happy to talk about this topic, which is the newer insights in prediction of preeclampsia. So we know that preeclampsia have been, going around and a little bit change happening since 2018. And what we consider is that preeclampsia is not just hypertension and proteinuria, but the presence of organ dysfunction in presence of blood pressure is also preeclampsia. So we talk about screening for, so when we talk about the newer insights, want to talk about biomarkers. So I will talk about this in 2 stages. One is the screening for PE, which is not that much of a newer insight, I would say. And the second trimester, which is the SFLT and PLGF. So quickly covering the first trimester, we know that, we should all screen for PE using the first trimester. And I think Dr. Gorakh has talked about the usage of aspirin, which is dependent on the screening for preeclampsia. We all must screen using the risk factors, which is included in the Gestosis risk scoring, age, parity, previous history, interpregnancy interval, and all of these factors taken together. But the fact that maternity, you will be giving aspirin to 30% of your population, detection rate of only 40%. So that is a sub.
The voice is breaking. Aparna ma'am, can you just correct the mic? The voice is breaking.
Is it better?
Yes, ma'am.
Better now? So if we use the other, if we to the history, if we add maternal factors in addition to history, then we use like blood pressure. So if we add blood pressure to the maternal factors, we increase the detection rate to 60%. And if we add uterine artery Doppler, we increase the prediction to 82%. And that's the purpose of using all 3 of them together. And we come to the role of biomarkers as a screening tool. The most commonly available biomarkers are SFLT and PLGF. SFLT is essentially an anti-angiogenic marker and PLGF is a pro-angiogenic marker. So the presence of PLGF is a good factor and it prevents preeclampsia, and SFLT is an anti-angiogenic factor and it kind of promotes preeclampsia. In the first trimester, there is role of PLGF. In the second and third trimester, there is role of SFLT, PLGF, both ratio. So if we add PLGF in the first trimester to the already being used parameters, which is maternal risk factor, uterine artery Doppler, blood pressure, and the biomarker, we increase the detection rate to 90% with a false positivity between 5 to 20%. And this is an ideal method, so to say, to predict preeclampsia. Having said that, yes, we have those questions about affordability and all of those things, but think preeclampsia is our motto, and we must use some form of screening for preeclampsia and try to give aspirin. The ideal is we have mentioned and combine all of them together to a good, and anybody who is in the risk category of more than 1 in 100 should be given aspirin. Simple approach is we can go to this website, look at the calculator, enter the history that we have, whatever medical history we have, and the mean arterial pressure, the uterine artery Doppler, include the biochemistry if we have, and even if we do not have, just enter that we do not have, and the software will give us, which is free of cost, whether this woman is at high risk of preeclampsia, and then her ask. The first tracker and screening preeclampsia include a free PET-CG, PLGF, mean uterine arterial pressure, all of together.
I think she's lost connectivity. Neha, can you call up Dr. Aparna and tell
Yes,
her?
ma'am. Yes,
voice
ma'am.
is
I'll
also
do that.
not so clear.
Am I audible now?
Aparna, your voice is cracking and it went off. Can you move the source or something like that?
Yeah. Is it better now?
Yeah, it's better now. Better.
Ma'am, it's breaking in
That will be
between.
better.
Can
Okay,
Aparna
just give me a minute. Yeah, is it better? Kind of.
Yes,
Aparna,
ma'am.
if you switch off your video, it would be better.
I
The net
did.
is unstable.
I did.
Yeah, Redmi Note 10S.
Yeah, I have switched it off.
Voice is
Uh,
clear. Voice is clear,
yeah.
Aparna. You can share screen.
I'll just share screen.
Good evening, Dr. Prakash sir.
Yeah, good evening, good evening.
Connect only. Yes. Should I carry on? I hope I'm audible now. I switched off my
Yes,
video also.
yes, Aparna. Yeah, you're audible.
So now this was something which was not very new, and I think we are all trying to do some form of preeclampsia screening. But now I want to move to the second trimester screening and the use of SFLT PLGF ratio. Whatever I'm talking is from what we are already doing and from our experience here. So is there any role of SFLT PLGF in diagnosis of preeclampsia, prediction, and what is the role in established preeclampsia patient? Now, in women, this was the first study which talked about the role of SFLT PLGF ratio right back in 2014. So it's now more than 10 years that this ratio has been there. So in early onset preeclampsia, if you have a ratio of less than or equal to 33, then it kind of rules out preeclampsia. So this lady does not have preeclampsia. So this is a rule out of preeclampsia. But if you have a ratio which is more than 85, then it is supposed to say that, okay, this lady has preeclampsia. Similarly, for late onset preeclampsia, that is for more than 34 weeks, you have a situation where you have a less than 33 value will say that, okay, this lady does not have preeclampsia, and more than 110, you will say it is a rule in. Now, just to say that why this low ratio will rule out preeclampsia, because a low ratio tells us that PLGF is the denominator, and a high PLGF ratio will tell us that yes, it's good, all is good, PLGF is high, and a low ratio is good and the preeclampsia is ruled out. Here the value, the worse it is for us and the preeclampsia. So I'll just talk about this patient, that she's a third gravida, previous 2 abortions, 10-year-old, 35 weeks pregnancy. She had a mild pedal edema which was gradually increasing. She had an occasional blood pressure of 140 by 90 and more likely to be 135 by 80. Her CBC LFT was normal. 24-hour urine protein was also normal. Now in this particular lady, I did an SFLT PLGF ratio. I was not sure she's hypertension, she's preeclampsia or not, but the SFLT PLGF ratio came out to be 162. Now, in this patient, I decided to, continue the induction of labor. So go ahead. So this lady came out to be 162. So I decided that, okay, this goes towards preeclampsia. So decided to go ahead with induction of labor at 37 weeks. Intrapartum, she had 170 by 100 blood pressure requiring IV labetalol. And postpartum, she needed labetalol. So this is a kind of a test which kind of tells us that, okay, is she already preeclampsia? Does she need, induction at 37? So it helps in our clinical triaging. What is she gestational hypertension or is she preeclampsia? So this is one instance in which, so more and more this is coming into the guidelines for diagnosis of preeclampsia in women who are at suspicion of preeclampsia. Now, this is another case who was a young girl, a doctor herself, 31-year-old primary gravida. She was in the first trimester screening for preeclampsia based on FMF guidelines. She turned out to be at high risk for preeclampsia. She was already on 150 milligram Ecosprin. In the second trimester, on the early FGR, on the level 2 scan, she turned out to be early FGR at 22 weeks. However, her anatomy scan was normal, her anomaly scan was all normal, and she refused amniocentesis and to look for any genetic cause. Maternal torch was negative. Now we were in a fix that how do we go about it? How do we rule out that this is not a genetic cause? And she's just 22 weeks. She continued with the pregnancy. So in this lady, we got an SFLT PLGF ratio done in an early onset fetal growth restriction, which came out to be 192. So this told us that this is a cause of placental insufficiency leading to early onset fetal fetal growth restriction. So we were kind of all right that, okay, this is not a genetic or an infectious cause of early onset fetal growth restriction. She was monitored bi-weekly, received steroid cover at 28 weeks, AEDF at 29 weeks, monitored, had deceleration at 31 weeks, and then went on till 31 plus 4 weeks, and we delivered a female baby of 1000 grams. So in this particular case, we were quite relieved when we had a high SFLT PLGF ratio, because it kind of told us. And this lady also developed high blood pressure later on, 2 weeks after the value were actually raised. So this kind of told us that, okay, there is some uteroplacental insufficiency which is happening much earlier than it actually manifested as a high blood pressure in the mother. So how does it predict? So the first trial, the prognosis trial, which told us that it has a role in prediction of PE. So in this, 100 women who had an SFLT PLGF ratio of more than 38 for prediction of PE had a 66% sensitivity and 83% specificity. This was followed by the post hoc analysis by Zeisler and the INSPIRE trial, and the in Asia also it has been trial, where SFLT PLGF ratio of more than 85 was able to rule in preeclampsia. So if we want to remember some of the numbers of biomarkers, so if you have a ratio of less than 38, you rule out preeclampsia. If you have a ratio of more than 85 in less than 30, you rule in preeclampsia. And if you have a ratio of more than 110 in more than 34, you rule in preeclampsia. So you have to remember 3 numbers: less than 38, more than 85, and more than 110. So to give an example of another case, she was a doctor, 36 years, 35 weeks, pedal edema, 130, 85 blood pressure. Again, I was worried. Is she preeclampsia? Is she just gestational hypertension? I got her SFLT PLGF ratio 4.09. I said, nothing is going to happen. You are already fine. So she progressed normally, went on to have a normal delivery, and the baby and the mother were fine. So it kind of gives us an option how the disease progression is going to be. Is she going to worsen? Again, monitoring the disease progression, so it can predict. So a known case of preeclampsia, is there a role? You know, you're sitting on preeclampsia. Can we predict how the disease is going to behave? So it has been seen that if the ratio is more than 85, then the days from diagnosis to delivery is almost less than 6. But if it is less than 85, it is more than 14. So it can also tell you how long the pregnancy is going to carry on. So say, for example, this particular case, she was 33 weeks. She came to us with a complaint of headache, BP of 150, 102. She was controlled on hypertensive, started on Lebetlol, and discharged after 3 days. There is nothing wrong in this particular management. However, this lady came back. So we discharged and we followed up. However, this lady came back after 3 days with abruption and fetal distress. Now, at that particular time, we did send an SFLT PLGF ratio, but the report came to us after 3 days. By that time, she had an abruption and fetal distress, and the ratio was 89.22. Now, the question is, if we had this report before, it predicts an adverse outcome. Would we have discharged that patient? Would we have kept that patient on monitoring? So that is something, again, for food for thought, that it predicts an adverse outcome in women with known preeclampsia. So there is a lot of implication in trying to understand this. So any ratio which is more than 85, number one, it predicts that there would be a indication for delivery within the next 6 days. So that's another thing. So probably you need to monitor that woman more carefully. So this is our experience that we recently published of more than 40 patients who had SFLT PLGF ratio of more than 38, in which 75% had PE and 20% did not have PE. And also they had shorter time to delivery and ROC of 0.8 of identifying patients at high risk. And so it has been seen that between 30 to 34 weeks, so it is also an indicator for severe preeclampsia, a ratio of more than 85, like Pyers and longitudinal evaluation of SFLT. So again, so this is now a novel concept, a novel evolving concept, that any woman who's coming to us with an early onset fetal growth restriction, should we include SFLT PLGF as a first line investigation for the management of for the diagnosis of this condition. And we've looked into and in the process of publishing this case series of these 9 patients in which we had a high ratio of SFLT PLGF, proving that uteroplacental insufficiency is the predominant cause of early onset fetal growth restriction, whereby you can actually avoid the costly genetic testing in these particular women even before you have frank signs of hypertension. They would probably develop hypertension much later, but it first presents as early onset fetal growth restriction. So to summarize, the use of in these particular women for early onset, none of them had hypertensive disorders at presentation. Torch was negative, genetic testing was normal, all had SFLT PLGF ratio, which were raised. So in these women, they may actually spare the cost of costly genetic testing. Now, in the end, I would like to move on from the point of SFLT PLGF to point of care tests. And we recently published this article in Pregnancy Hypertension, where we looked at urinary Congo Red point of care device for prediction of preeclampsia. So this was done as a multicentric trial of 600 women from all hospitals of Delhi. And we showed that it has a positive predictive value of out preeclampsia among with around a negative predictive value of 98%. So this is a good test to rule out preeclampsia and tell them that nothing is going to happen. So to conclude, the current role of PLGF is for screening, for SFLT and PLGF is for diagnosis, prediction, and to predict the course of the disease in proven preeclampsia patient. And to say the least, it is absolutely mandatory that we do some form of first trimester screening for preeclampsia and institute the aspirin prophylaxis. So we must think SFLT PLGF and include and expand the role of biomarkers for the management of preeclampsia. So in the end, I would like to invite everybody for AICOG, which is coming in 2026. Thank you very much.
Thank you, ma'am, for a wonderful and crisp lecture. I would now like to ask the chairperson to say a few words and invite the next speaker. Asha, ma'am.
That was a one now, and so many points clarified regarding the biomarkers, and it will be really hopeful that more centers will start with this biomarker and gain the benefit. And now we have Dr. Prakash Mehta to speak on antihypertensives. Dr. Mehta is the Chief of Division of Maternal and Fetal Medicine and head of the Department of OBGYN, Bhagwan Mahavir Jain Hospital, Bangalore, post-PG fellowship teacher and examiner in maternal medicine and OBGYN, many orations and numerous articles in various journals, President Society of Maternal Medicine, past President of OBGYN, and now to you I present Prakash Mehta.
Thank you. And it's always a pleasure to be on this kind of a program.
Sorry to interrupt, sir. Aparna, can you answer the questions in the chat box? There are lots of questions in the chat box too. Sir, please continue.
So the next topic would be on how do we use antihypertensives? When do we use? When do we start? How do we change? And how do we adjust the dose for antihypertensives? Now, antihypertensives are important because all complications of hypertensive disorders of pregnancy, starting from ARDS to accidental hemorrhage to intracranial hemorrhage, all are dependent on the blood pressure. So unless we control the blood pressure, these complications are likely to come in. Now, there are certain caveats when you do use antihypertensives. The first and the most important is that antihypertensive therapy should be administered in a timely fashion. Start with monotherapy. Whatever may be your blood pressure, don't start with 2 and 3 and 4 drugs like that. And don't jump from drug to drug. Give the drug enough time to work. Also remember that while you are using antihypertensives and bringing down the blood pressure levels alone are not reliable for stratifying the risk in pre-eclamptic patients because of the maternal end organ disease and the uteroplacental dysfunction, which could occur even with a minimum rise of blood pressure. So just because I've used antihypertensives doesn't mean that I can ignore this patient. Her blood pressure has now come down to normal, but I should not ignore the patient because preeclampsia is a multifaceted syndrome. Also remember that the main benefit for the treatment of hypertension during pregnancy is maternal. The fetal is not going to get any advantage because you have used antihypertensives. And the first line of drugs that we generally use would be labetalol, nifedipine, and of course the now extinct methyl-dopa, which was one of the, anybody senior here will agree with me that methyl-dopa was one of the most wonderful drugs that we had, but unfortunately not available anymore. But let us also remember that there is no ideal antihypertensive. Nobody can tell you that use this drug or use that drug and it's going to work better. It doesn't work that way. Use the drug with which you are most familiar with, the drug which you are using most often and you know how to use it, and that would become your ideal antihypertensive. So now when do we start the antihypertensive agents? We know that the antihypertensives could be given either oral or for IV. Now, to start an oral antihypertensive agent, any BP persistent above 140 by 90 millimeters of mercury, you should start antihypertensive. And the aim is to maintain the blood pressure at 135/85. Don't take her down to 110/70 or 100 by 60 and so on. That is not required. That's going to affect the fetus even more because the placental perfusion is going to come down. So our aim is to keep the blood pressure at about 135/85. So now if the moment the BP is 140 by 90, we have got the three drugs of choice. As I told you, methyl-dopa is not available now. So we are not going to consider that. Labetalol would be the first drug. You give in the dose of 200 milligram and you can go up to 1200 milligram per day. But unfortunately, it comes with its own side effect. FGR, neonatal hypoglycemia can always come in. Nifedipine, we have to use sustained release. Remember, it's only in acute conditions that you would want a short-acting nifedipine. When you're using it for a chronic use, it has to be a sustained release nifedipine. Give it in the dose of 10 to 30 milligrams per day. There is a theoretical fear that it may inhibit labor or it can cause postpartum hemorrhage later on, but it is just theoretical and you will generally not see that. Now, as I already told you, the order of starting may be changed based on clinical experiences and go up to a maximum of 3 oral drugs. Now, hydralazine, which was there in the olden days and fell into disrepute, has come back again in a big way. And the use of hydralazine oral tablet is wonderful when you have a kind of a resistant hypertension. It works very well. You get it as a 25 milligram tablet and works very well. But we should also know that certain drugs are contraindicated. ACE inhibitors, the ARBs, which can cause fetal renal damage, the beta blockers and diuretics are generally not indicated during pregnancy. But please remember, if your patient has taken ACE inhibitor or an ARB early in the pregnancy, and she comes to you at around 11 weeks or 12 weeks saying that I've already taken ARBs, the chronic hypertensive ones, don't hesitate to tell her that, no, lady, don't worry, everything is going to be fine. Because just because she has used ARB or an ACE inhibitor early in the pregnancy, it is not an indication for termination of pregnancy. You should continue that pregnancy because the chance of malformations are very small. But knowingly, we don't start ACE or ARBs. So among the drugs, labetalol, we all know there's a combined alpha and a non-selective beta blocker. It's not a selective beta blocker. That's where some of its side effects come from. Non-selective beta blocker, it can be oral or parenteral. The beta blockade predominates when labetalol is administered parenterally. And you have to be very careful when you use it in a patient with asthma. And like I already told you, neonatal bradycardia and hypoglycemia can occur. So if a patient has been on high doses of labetalol, ensure that your pediatrician checks the baby's blood sugar. Nifedipine is one of the very popular drugs. It is my favorite drug. This is the drug I use for most of my patients, and it is very effective. we all know it's a calcium channel blocker, blocks the smooth muscles in the vessels and causes a vasodilatation. And extended release formulation should be used for non-severe hypertension, which I already told before. Now, vitamin D has been seen to enhance the effectiveness of nifedipine. So if with nifedipine simple dose, if your blood pressure is not getting controlled and you are hesitant to change to any other drug, please try adding a vitamin D. It may help. Hydralazine, I told you, is again one of my very favorite drugs for severe hypertension or resistant hypertensions. This is my favorite drug. It's a direct acting vasodilator that is available in oral and parenteral formulations. Oral dose is 25 milligram TID or QID, but you can always start with 25 milligram BD and then go on increasing it. There are small concerns there. Maternal hypertension can occur, especially with parenteral one, headache, tachycardia. But the 2018 network meta-analysis proved that all these were again theoretical and were not seen when you use it on real-time patients. Then we have the many other drugs like clonidine, or you have nitroprusside, and once in a way, with a good selection, you can even use hydrochlorothiazide, because in most of the time in preeclampsia, we are worried since there is already a hemoconcentration and you use a diuretic, then the hemoconcentration is going to worsen. But there are certain situations where you could use hydrochlorothiazide and get your control well. Again, I repeat, do not use ACE inhibitors and ARBs. Now, what kind of a control do we do? Once upon a time, we were told that do not control the blood pressure very much. It can make the baby suffer. But the CHIPS trial that came in proved that a tight control of hypertension is for the benefit of the mother without any additional risk to the neonate. So make sure that you do a very tight control. I told you 135/85 would be what the figure that you're going to look at, not 110/70 or 160, what the patient had maybe prior to getting the hypertension. Stick to 135/85 and your patient will do very well. So now how do we get tight control? So I told you tight control, the target diastolic blood pressure is 85 millimeters of mercury. So if the diastolic blood pressure goes below 80 millimeters of mercury, then you stop the antihypertensive medication or decrease the dose of existing antihypertensive medication. Don't take her to that level. You want 85. Of course, if it is 85, you're not going to change your management. But if the diastolic blood pressure is more than 85, then you're going to add another antihypertensive or increase the dose of the antihypertensive that you have been using so far. Same thing with the systolic blood pressure. If it touches 160, you have to increase the dose or add in other drug. So how do we do the dose titration? This is a very nice figure by Laura Maggie. She has done a lot of work on this, and the titration is you use your first line drug. Your first line drug could be labetalol, it could be nifedipine, it could be anything. And start with a low dose. If you're using labetalol, I'll just stick to labetalol and nifedipine XL, that is extended release nifedipine. 100 TID or QID you will start with. Nifedipine, if you're using, you will start with 30 OD. Then, if the BP is not controlled, then proceed to the medium dose of the antihypertensive. If you're using labetalol, increase it to 200 milligram TID or QID. If you're using nifedipine, now make it 20 milligram BD. The BP is still not controlled even on a medium dosage, then consider adding another low dose medication rather than going for the higher dose of the same medication. Although I told you before that 1200 milligram of labetalol can be given. Yes, that is the maximum dose we can give. But when we are treating a patient, do not go to 1200 milligram full dose. If by 800 milligram, 200 milligram QID will become to 800 milligram per day. If by 800 milligram per day, if the BP is not controlled, it is time now to add another antihypertensive. So this is how we go about titrating the dose. Now we come to the next aspect, severe hypertension. Well, most of the audience here may not come across the situation because unless you have an ICU setup with you and HDU setup with you, The moment the patient has got a severe hypertension, you will have to refer the patient to a higher center rather than keep her with you and face all the problems. But for those who are working with a HDU backup, then whenever there is a severe hypertension, then you use the intravenous form of drugs. You will use labetalol, 10 to 20 milligram of IV, not controlled, go up to 20 to up to 80 milligram every 10 to 30 minutes to a maximum cumulative dose of 300 milligram. But I personally prefer in my practice a constant infusion of 1 to 2 milligram per minute IV. Now, by doing this, what I achieve is I can titrate my doses to adjust that acute BP. And also, if the BP starts coming down, I can bring down the dose. So I prefer IV infusion rather than a push. There are a very fewer side effects there. Sometimes you get a decompensated cardiac function. You could get a heart block or a bradycardia. So obviously, because your patient is in HDU or ICU, a continuous ECG is definitely going on for these patients. Hydralazine, I told you, is my favorite drug again, where no response comes with the initial drugs. You give 5 milligram of IV or IM, then 5 to 10 milligram of IV every 20 to 40 minutes with a maximum cumulative dose of 20 milligram, or you can give an infusion of 0.5 to 1 milligram per hour. Hypertension, headache, and abnormal fetal heart rate tracings could come in. Nifedipine tablets, you give 10 to milligram orally, repeat in 20 minutes if needed, then 10 to 20 milligram every 2 to 6 hours, and reach a maximum dose of 180 milligram. The problem here is you will observe a reflex tachycardia and a headache also, the patient can tell, which could confuse you whether it's an eclampsia headache or whether it's a nifedipine headache. Now remember, nifedipine plus Maxil can result in increased incidence of pulmonary edema or myocardial infarction. But again, I repeat, it's only a theoretical observation. I have been using, and there are many centers in the world using a combined nifedipine and magnesium sulfate, and nothing happens in these patients. So do not hesitate to use this combination whenever required. And also we need to remember that whenever there is a severe hypertension, lower the BP promptly but slowly. If the BP is 240 by 140, I wanted to bring down very slowly to about 180, 100, and then bring it down further. I don't want straight away a 130, 90 BP for this patient, because by doing that, I'll be causing more problems for the patient. Now, there are other alternative drugs available in the ICU setup. You can use an NTG infusion in the dose of 0.5 or 1 microgram per kg per minute, or you can use oral clonidine. And if the hypertension is not getting controlled at all, then possibly sodium nitroprusside, 0.5 micrograms per kg can be used. I repeat again, all these drugs have to be used in an HDU setup at least. And if you do not have facilities, please refer this patient at this stage rather than referring her a little late. Now, there is something called as an individualized antihypertensive therapy. We know we are all moving toward now individualized medicine in all fields. So similarly for antihypertensive therapy also, we have an individualized therapy based on hemodynamic patterns. Now, when you have high blood pressure, it could be due to two kinds of patients. One is with a lower heart rate and lower cardiac stroke volume. So it will be a vasoconstriction with high resistance phenotype. And these are associated with more severe hypertension and FGR. So for such patients, a vasodilator would be much better. In contrast, you have women who have got a higher heart rate and stroke volume. These are called as the hyperdynamic phenotype. These are more successfully treated with oral labetalol. So for one, you have to use a vasodilator like nifedipine. For the others, you need to use an oral labetalol. So personalized hemodynamic assessment holds the clue now. Now, finally, to the last aspect of the treatment, that is the postpartum treatment. Please remember, postpartum treatment is extremely important, and antihypertensives to be continued as per blood pressure. Reduction of dosage may be required. Pre-pregnancy, normotensive or unknown, it is reasonable to stop oral antihypertensives after 3 to 4 weeks. But you must check the blood pressure continuously and call her back at 6 months to see if the hypertension is controlled or not. All commonly used antihypertensive agents can be used. They do not affect the breast milk secretion. Very small amount is secreted in the breast milk, so don't worry about that. Now, this is the time when you start using the oral loop diuretics like furosemide. Now, after delivery, if you use furosemide, 25 milligram orally per day for 3 days at least, then you will find that there is a faster normalization of the blood pressure and decreased use of antihypertensives. This is important because the extravascular fluid now goes back into the intravascular space, and the diuretics that you're using will push it out of the body so that the hypertension gets controlled very well. So a very good role for Lasix in the postpartum period. So to conclude, points to remember: antihypertensives halve the risk of progression to severe hypertension and reduction in other maternal complications, not totally, but reduces them. Magnesium sulfate is not an antihypertensive. Please remember that. It's an anticonvulsant, not an antihypertensive. Nifedipine and magnesium sulfate can be used together. At present, the blood pressure treatment targets used in the clinics are same as used at home. Now we are more and more into home blood pressure monitoring. The targets at home and in the clinic are absolutely the same. And it is still unclear whether there is an optimal antihypertensive and whether there is a combination that is available. Individualized care may be most appropriate. Postnatal care and blood pressure control are very, very important. So thank you all for a very patient hearing. Now, treating and use with antihypertensive is like doing gymnastics. You have to do all kinds of circuits to get through to this patient, but you will be successful if you're a good gymnast. Thank you.
Thank you so much, sir. It was wonderful, and you had explained everything in the given time. And thank you so much for the wonderful presentation.
Sir, there are some questions for Aparna also, but she has left the program. Can you answer both the type of questions, sir, for both the presenters?
Sure, I'll do that.
Yeah. Thank you so much, sir. Wonderful as always. Thank you.
Now I would like to begin with the session 2. I would like to invite Dr. Meena Samant ma'am. Ma'am is Senior Consultant and HOD of the Department of Obs and Gynae, Kurji, Holy Family Hospital, Patna. She's the President of Patna Obs and Gynae Society 2023-2025 and a Governing Council member of ICOG 2023-2025. Welcome, ma'am.
Thank you, Dr. Meena.
The next chairperson for the session is Dr. Sandhya Rani. Ma'am is Obs and Gynae consultant in Orissa. Ma'am is a life member of IMA AMS secretary. She's the secretary of IMA AMS Orissa and has been a member of Oncology Committee and the Breast Committee. She has been the president. She's the president of IMA MS Behrampur. Welcome, ma'am.
Thank you, Nehar. Thank you, Charmila madam. Good evening to everyone.
Good evening. I would request ma'am to please introduce the speaker for the next session.
So good evening, everyone. It's a pleasure to invite Dr. Chinmay Ratha, who we know is a diploma in fetal medicine from UK. And we also have in this session Dr. Manju Puri. So first the speaker is Dr. Charmila. Sorry, Dr. Chinmay. Can I have a speaking? So she's going to tell us about the management of fetus during in hypertensive disorders of pregnancy. So I think we go to Dr. Puri and Dr. Girja in due course. So Dr. Chinmay, over to you.
Thank you so much, Meena ma'am, for the kind introduction. At the outset, I thank Charmila ma'am for the opportunity to present this topic on management of the fetus in hypertensive disorders of pregnancy, because hypertensive disorders of pregnancy are major challenges for obstetricians, and whenever the obstetrician thinks, she thinks of the mother first, and as it always should be. However, in this condition of hypertensive disorders of pregnancy, which includes, of course, all the other issues like chronic hypertension, gestational hypertension, preeclampsia, and eclampsia, the mother is definitely the primary target of the disease and the primary cause of concern for the clinician. But there is an invisible patient inside, which is the whole, the purpose of pregnancy. And this whole disease process ends up affecting that invisible patient also. So there is a lot of fetal morbidity and mortality associated in hypertensive disorders of pregnancy, and how to manage this fetus becomes a real challenge for the clinician. So all hypertensive disorders of pregnancy end up disrupting the placental function and leading to adverse fetal outcomes like growth restriction, like low birth weight, like small for dates, and sometimes prematurity, which may be forced on the fetus because of the decision for delivery in this hypertensive disorder. So overall, there is an increase in perinatal morbidity and mortality. So when it comes to managing the fetus in hypertensive disorders, it is very much like, balancing too many things. And often we tend to balance, sometimes we tend to not be successful in doing that. But effective fetal monitoring and management is critical to optimizing the outcomes. And when it is effective fetal monitoring, both the prediction and management of problems are important, because we've just heard from the previous speakers how prediction is possible for a lot of conditions and prevention is possible by some methods, but you have to really fine tune your predictive protocols and institute your management strategies early to avoid any kind of avoidable fetal morbidity or mortality. So one of the important things in prediction is prediction of preeclampsia, and prediction of preeclampsia now can be started in the first trimester. And we know the role of history, we know the role of biomarkers, which already Dr. Aparna has dealt with. But in the fetal medicine clinic, there is an important intervention that we do in terms of predicting preeclampsia. That is the first trimester uterine artery Dopplers. So the uterine artery Doppler waveform is a very good indicator of how good the placentation is happening, because the uterus as such is a very muscular organ and the uterine artery resistance is generally high in a non-pregnant state. But as pregnancy progresses, there is a serial decrease in the resistance of the flow in the uterine artery, seen by decreased pulsatility index, decreased diastolic notches, and improved diastolic flow, which is an indication of good placentation. When that fails to happen, high uterine artery resistance, high uterine artery impedance is something which predicts the possibility of preeclampsia, growth restriction, and all the adverse pregnancy outcomes that are associated with this type of abnormality. So in that concept of inversion of pyramid of antenatal care, this prediction has come into the first trimester. Although the problems generally tend to precipitate in the second and third trimester, doing an effective prediction in first trimester would be one of the first interventions that an obstetrician can do in order to achieve a good fetal outcome. Now, when we talk about management, we talk about a very specific part of the clinical activity, but I think it all starts from the point of prediction, because you can then take effective steps of prevention and improve the final outcome. So the prediction involves several parameters: history-based parameter, ultrasound-based parameters, biochemistry-based parameters, and biophysical markers. Dr. Aparna has already shown us that FMF protocol, which is generally used for prediction, and we can get a very numerical value about how likely is this woman to develop preeclampsia at different gestations. And if it is early onset preeclampsia, then there is a role of prevention also. One of the newer methods of predicting further complications with regard to hypertensive disorders is the maternal ophthalmic artery Doppler. Now, till now, we were concentrating on the uteroplacental flows because we were thinking it's only the uterine artery which gets affected by the placentation. But there's a new concept that has come up in preeclampsia, that preeclampsia may not be a purely placental disease. It may just be a placental manifestation of a pre-existing cardiovascular dysfunction in the mother. And therefore, if we looked at the maternal cardiovascular function even before the actual placentation has started, then also we can make a prediction of preeclampsia. And for that, the ophthalmic artery Doppler is something that is coming in. It's a maternal ophthalmic artery Doppler. It is done in the first trimester clinic using the same ultrasound machine, but a different probe, which is a linear probe. And we compare the two systolic flows that happen in the ophthalmic artery for prediction of preeclampsia. So whenever we have this prediction of maternal preeclampsia, maternal hypertensive disorders, if we can predict something which indicates an earlier onset of the hypertensive disorders or a more severe form of hypertensive disorders, we will anticipate fetal complications. So prediction ho gaya. Now, what can we do to make things better in that pregnancy. So the whole concept of inverting the pyramid of antenatal care is you instill certain interventions in the first trimester, which will make your task easier in the third trimester, because final outcome will only be after the third trimester. But if you start working in the first trimester, you will probably reach the third trimester in a more comfortable zone. So we now are familiar with these screening reports. And once we see the screening report as high risk, we have to then think of the preventive methods. So the one molecule that has definitely proven to be useful in prevention of early onset preeclampsia or preventing the complications of early onset preeclampsia, or sometimes it is thought that it just delays the onset of preeclampsia, is the low dose aspirin. Now, we've heard Dr. Gorak talk about the 75 milligram per day concept, which has been given by Gestosis India, and the ASPRE trial had earlier talked about the 150 milligram per day. So while it still remains open for discussion regarding the actual mechanism of what we need to prevent, we know that at least starting low dose aspirin in the first trimester makes sense. His argument about the prostacyclin and the thromboxane pathway is very, very compelling, and that makes sense also in many ways. So I am not going to get into that argument right now, because that is still open for the guidelines to clarify it for us. But whether it is 75, whether it is 150, at least start something. Start something in high risk cases in the first trimester of pregnancy, so that you aid in the placentation. And starting this before 16 weeks makes sense, because once 16 weeks is crossed, then the second phase of placentation has already started. And therefore, we need to start the prevention method. So managing the fetus later will become easier if you start the preventive strategies early on in pregnancy. Then what is it that we are worried in the fetus? A fetus which has a poorly developed placenta, or a mother who's having hypertension and is not able to perfuse well into the uteroplacental zone, will lead to fetal growth restriction. So ultimately, the management for the fetus becomes the challenge of fetal growth restriction. So fetal growth restriction, again, is something which we are very familiar with. But when it comes via the hypertensive disorders of pregnancy, you need to think that what exactly can we change? Can we deliver this fetus? Because the hypertensive disorder of pregnancy is a maternal problem. And if you make the fetus ex utero, where it is no more having the challenges of the maternal problems, then it is great. So that will be delivery. But when do you deliver the fetus? You cannot deliver the fetus at 12 weeks. You cannot deliver the fetus at 24 weeks. You cannot deliver the fetus at 20 weeks. So you need to optimize the in utero environment till the time that it can be surviving ex utero. So here the challenge will be to improve the placental circulation as much as possible in utero to make ex utero life better for the fetus. So what are those principles that we follow? We follow the principles of following fetal Dopplers. What is fetal Doppler? Fetal Doppler is study of each vessel of the fetus in order to say how much compromise this fetus is taking in, how much more compromise can it tolerate before it actually decompensates. So in hypertensive disorders of pregnancy, we expect the pattern of the early onset IOGR phenomenon. And in that case, we look at the umbilical arteries first. The umbilical artery is the peripheral resistance of the fetus, and gradually it shows deterioration in the form of increased resistance, absent diastolic flow, and reverse diastolic flow. Then comes the ductus venosus, which is the incoming oxygenated blood from the mother, and that shows compromise in the form of absent A wave and reversed A wave. So when you see serial obliteration of the reassuring waves and the Doppler, you realize that this fetus is heading towards compromise. Sometimes, rarely, you may have the late onset IOGR problems in the third trimester. Suppose the mother suddenly develops a hypertensive situation in the third trimester. The changes in the Dopplers might be very, very subtle, and they may not actually lead to problems in the umbilical or MCA altogether, but there may be just slight alterations in the pulsatility index, and that can be seen by the cerebroplacental ratio, which is very useful in telling us that the fetus is having some degree of compromise. But how do you decide? When it comes to management, you have to have a protocol. So this is the stage-based management for fetal growth restriction based on the fetal Dopplers, and the maternal uterine artery Dopplers are complementary to the fetal Dopplers in assessing the overall uteroplacental circulation. And this makes a lot of sense even in the background of hypertensive disorders of pregnancy. So depending on the gestational age of the fetus, you will allow a certain degree of compromise. For example, if it is 37 weeks of pregnancy, then you don't need to wait till the Dopplers are really bad, because if it is growth restriction, if it is 37 weeks of pregnancy, you know that now the baby is full term and can be delivered and managed ex utero. So even induction of labor is fine, and allow the baby to come out and then thrive outside, because the problems inside are because of maternal hypertension. But if it is 34 weeks, if it is 30 weeks, if it is 26 weeks, you don't want to just pull out a baby without compelling reason. So at 34 weeks, absent diastolic flow in the umbilical artery. At 30 weeks, reverse diastolic flow in the umbilical artery. And at 26 weeks, only when the ductus venosus is also abnormal, and with a lot of star marks put there, because you need to also talk to the neonatologist whether or not this baby will be properly salvageable if you deliver the baby. So the management of the fetus will depend on multiple factors, and at all stages, the maternal medical condition will take the foreground. So you may actually deliver a baby at 34 weeks, even if the Dopplers are not bad, if the mother is going into impending eclampsia or preeclampsia. So iatrogenic prematurity or unavoidable prematurity is another challenge that you will have to face. In addition to this, serial worsening of the placental problems. So in placental problems, you want to deliver the baby somewhere between hypoxia and acidosis, because as we have repeatedly understood, hypoxia can cause fetal damage, but that is reversible. Acidosis causes irreversible fetal damage. So if you want an intact survival for a fetus after 28 weeks of gestation, choose a time between hypoxia and acidosis. The problems with the Dopplers are shown there, and this is taken from the very seminal paper of Figueras et al., where they have really described how placental disease deteriorates gradually and leads to in utero fetal demise. So if we are at 24 weeks and there is significant demise, we may just have to compromise with it. We may have to counsel the mother that, unfortunately, we are not able to do anything and you may lose this pregnancy. But if everything is manageable and the mother's condition is okay, then we will try and deliver the baby at a time when it is easily manageable postnatally. Coming to placental insufficiency in particular, when you talk about fetal management, let us not think that Dopplers are the only methods of fetal management. Dopplers will help us because they give us a quick alert. They give us a time frame after which things will get from bad to worse. The decision for delivery is not always dependent on the Dopplers, and especially after 34 weeks, we need to take help for other things like computerized CTG if that is available. If not, even a normal CTG will help, and other conditions like biophysical profile. So whenever we monitor fetal growth restriction, there is really no one method which is better than all the others, and we should learn to take the help of each and every method and use it rationally in the whole concept of fetal management. So is there something that you can treat the fetus? Now here I want to raise this issue because a lot of people are used to giving some medicines which will improve the fetal growth restriction inside. And one of the medicines that was used to in this context was the sildenafil. And let me tell you that sildenafil is a phosphodiesterase 5 inhibitor, and it was thought to be a cyclic GMP pathway activator to increase the nitric oxide at the cellular level and cause smooth muscle relaxation. But in terms of fetal growth restriction, the Strider trial has shown that there is no benefit of sildenafil, and there is a safety statement against sildenafil. So we should not be using sildenafil in management of fetal growth restriction or hypertensive disorders of pregnancy in a context of the fetal management. Then comes the role of the Dopplers, as we've already discussed. And as we progress towards, worsening Dopplers and risking fetal acidosis or fetal death, we may have to take a decision for delivery. But how do we take a decision for delivery? That is where the CTG comes into our rescue. And the CTG is a beautiful technology which will determine the need for delivery in about the next half an hour. If there is a pathological CTG, you can take a decision for delivery in the next half an hour. The role of Doppler is to give you an alert sign much before CTG changes, so that if you have to give steroids, if you have to push transfer the baby into a high dependency tertiary NICU, you can do that. But very rarely the decisions for delivery will be taken based on Doppler alone. So especially after 34 weeks, we should not be taking our decision for delivery only based on Doppler. We should take the aid of CTG also. So the CTG will work in this way, where you look at the baseline variability, accelerations and decelerations, and only when there are prolonged decelerations, you will consider that as a pathological CTG, prolonged late decelerations, and think about delivery based on that. The other important method of looking at the fetus is the biophysical profile. And I have just put a video here to show you how fetal breathing movements look in utero. The fetus does not breathe to take air, but it only breathes to move the diaphragm and the respiratory muscles. So when you see this kind of fetal breathing movement, you know that the fetal CNS is still active and really the baby is not so compromised inside. So these are different things that we do in the biophysical profile, where we assess the fetal tone, we look at the movements, we look at the fetal breathing movements, and say whether this baby really needs to be rescued by delivery or can still stay in utero despite hypertensive disorders of pregnancy in the mother. So there are methods of looking at it, and I think if people are very scared of doing a long biophysical profile, there is a method of doing a modified biophysical profile where you just look at the NST and the amniotic fluid index and take a decision. So in hypertensive disorders of pregnancy, the decision for delivery may be based on maternal situation, not merely on the fetal Doppler, and not only on the Doppler, but also on auxiliary methods of surveillance like the biophysical profile and the CTG. So in summary, if you want to manage a fetus in hypertensive disorders of pregnancy, well, try to intervene early. And I'm very happy that the next talk after this is Dr. Manju Puri's, where she's going to talk about preconceptional intervention. And that is very important because we have to make the in utero environment better for the fetus. That is the best service that we can give the fetus in hypertensive disorders of pregnancy. So when you have to manage, you have to predict, prevent, monitor, and deliver in time. There is no one method that I can tell you, okay, deliver everybody at this gestation or monitor everybody in this way, because each patient behaves differently in this condition. As obstetricians, you know the vagaries of hypertensive disorders of pregnancy. But when you're managing the fetus, try to optimize gestational age with fetal maturity and the level of compromise in the fetus so that we can get the fetus out just in time. But how we decide that and what is the outcome is like walking that tightrope. And this is not only walking, this is like cycling on a tightrope, because you have to put so many things in the right place at the right time. Thank you so much for this opportunity.
Thank you, Dr. Ratha. That was such a clear and crisp, and highlighting the first trimester retinal Dopplers. And yes, prematurity is a thing which could be iatrogenic as well as depending on the condition. In prematurity, we should not forget I think antenatal steroids and the neuroprotection as well. Thank you so much. It's always a pleasure to listen to. I think Dr. Sandhya, over to you.
She can introduce the next speaker because we're running a little late. Neha, please put the slide of Dr. Manju Puri, madam. Thank you, Chinmay. Wonderful talk as always.
Thank you, ma'am.
Thank you.
I would request the chairpersons to please introduce this Manju Puri ma'am.
Dr. Sandhya, please introduce Dr. Manju.
Good evening, everyone. Dr. Manju Puri is a director professor of the former. I am audible?
Yeah, Dr. Sandhya, this is my old, CV, so it is fine. I've retired from LHMC and I am now working as Professor Gynae at SGT Medical College, Gurugram. So thank you so much. Yeah. I superannuated actually. Yeah.
Yeah, now the podium is yours, madam. You are most welcome for your topic.
Yeah.
Thank you, madam, for your nice introduction.
Thank you so much. Good evening, everyone, and excellent talk by Chinmay. And now I think I'll be sharing my screen. And thank you for having me on this platform and giving me this opportunity. So thank you, Charmila. Right. So. I hope my screen is visible.
It's visible, ma'am. It's
Right.
correct. Yeah.
All right, so I am going to talk on preconceptual management of chronic hypertension. I think a very well thought of topic, because hypertension per se is becoming more common as we are having moms who are a little older, and the lifestyle has changed and more of non-communicable diseases are there now. So what is chronic hypertension? It is defined as hypertension diagnosed or present before pregnancy, or on at least 2 occasions before 20 weeks of gestation. So I think that is what is defined as chronic hypertension. And patients with a previous history of gestational hypertension are classified as chronic hypertension if hypertension persists for more than or equal to 12 weeks after birth. So there is the importance of following our patients who develop hypertension during pregnancy for at least we should call them for a 3-month visit. And in case they are still hypertensive, and when I'm talking about the hypertension here, I'm talking about more than or equal to 140 and or 90 mm mercury of blood pressure, right? So then again, they are to be labeled as hypertension, and they need to be told that they are hypertensive, and accordingly, we should counsel them for their subsequent pregnancies. So in patients presenting for the first time between 12 and 19 weeks of pregnancy, we all know there is a mid-trimester fall in the BP. So in case they are not there in the first trimester and they come a little late, so we can miss out on the diagnosis of chronic hypertension because of the 5 to 10 millimeter of mercury systolic blood pressure or diastolic blood pressure fall. And we all know that patients who are hypertensive also can have, in the first trimester, can have normal BP when they move on into the second trimester. So that is the catch here. Now, what are the BP cutoffs to define hypertension? So if we look at non-pregnant women or adults, we have this classification from American College of Cardiology and American Heart Association. In 2017, they brought down the levels. And normal BP is now considered as systolic blood pressure of less than 120 millimeter of mercury and diastolic of less than 80 millimeter of mercury. We have a terminology which says that elevated blood pressure is when the systolic BP is between 120 to 129 millimeter of mercury and diastolic is less than 80. So if there is only systolic rise lying in this range, we would say that the woman or the person has got elevated BP. Stage 1 hypertension is systolic blood pressure between 130 and 139 millimeter of mercury, or a diastolic BP between 80 to 89 millimeter of mercury. And stage 2 hypertension is when the systolic blood pressure is more than or equal to 140 millimeter of mercury, or diastolic blood pressure is more than or equal to 90 millimeter of mercury. That is what we normally consider during pregnancy as well. So now what is important is that pregnancy implications of this classification are not clear, right? And in pregnancy, we still consider cutoff values of systolic of more than or equal to 140 and a diastolic of more than or equal to 90 as the threshold to differentiate pregnant women who are at higher risk of adverse pregnancy outcomes. Now, what is the risk of chronic hypertension? So it is important for all of us to know that chronic hypertension is associated with maternal complications and also fetal complications. So maternal complications are in the form of severe hypertension, superimposed preeclampsia, abruptio placentae, which is directly related to the the rise in systolic blood pressure, higher rates of cesarean section, more postpartum hemorrhage. It can also be associated with renal insufficiency, stroke, myocardial infarction, pulmonary edema, maternal death. So a whole lot of complications are there. Although these complications are more when the hypertension is more severe and the patient is on a more number of antihypertensives, but still, I think this is something which we should be aware of. And when we look at the fetal complications, fetal growth restriction, preterm birth, which could be iatrogenic, which could be otherwise congenital anomalies, if they are on certain drugs, antihypertensives, which are not, safe for the fetus, it can result in stillbirth, it can result in neonatal death. So all these are the complications which are associated with chronic hypertension. Now, the risk of the chronic hypertension, they increase with the severity of hypertension and presence of end organ damage. Although most of the young patients may not have, very severe hypertension and, end organ damage may not be there because they are young and it may not be so long standing. But I think we all as obstetricians must be aware of this factor. Hence, the importance of preconceptional assessment and optimization. Now, what are the components of preconceptional management? First and foremost is counseling. And then we need to work up the patient for ruling out, find out what is the cause of hypertension. Young people are not supposed to have hypertension. So normally hypertension comes when we are more advanced in our age. So we need to rule out, are there any causes? We also need to do an end organ assessment for damage to the kidneys, to the heart. And then, of course, we need to look at the management of hypertension. So any patient who's entering the pregnancy should have well-controlled hypertension on safe antihypertensives. And of course, optimization of modifiable factors. We know that hypertension does not come alone. It comes with other NCDs like diabetes mellitus or obesity. So, when you have a combination of all these factors, the outcome becomes worse. So any of these factors which are there need to be optimized to have the best outcomes. Now, moving one by one. So preconceptual counseling, what do we need to counsel the patient for? So basically, we need to counsel the patient for, need to tell her that there is higher risk of adverse outcomes. That is one. We also need to tell her need for preconceptual assessment and optimization. So she has to undergo certain, we've got to take a detailed history, do her investigations. And in case we find anything which is not normal, we need to kind of optimize that by certain interventions. Then we also need to review the antihypertensive drugs. And we also sometimes might have to either we have to switch the, drugs to the safer. Just a second, please. I don't know what is this. Yeah. Give me a moment. Yeah. So we need to review the antihypertensives, and sometimes we have to switch, or sometimes we might have to stop. Then need for interventions like aspirin during pregnancy, and need for more frequent antenatal visits, maternal and fetal surveillance, and higher likelihood of hospitalization. So I think this is what should be made clear to the woman and the couple. Now, workup for ruling out causes for secondary hypertension. I think it is important that we have a physician on board because young people having hypertension is not a good thing. But then it's important that we need to have a physician on board, and it should be a multidisciplinary approach. Majority of the young hypertensives in the reproductive age group have essential hypertension. However, causes for secondary hypertension must be ruled out on history, examination, and investigations. Secondary hypertension must be suspected in those with severe or resistant hypertension, where the BP is above the goal, despite 3 antihypertensives of different groups. These are the ones who would have some underlying cause, and they are extremely high risk. So it is important that we must identify these patients. So these are also younger patients with severe hypertension and those who have no family history of hypertension. So what can be the possible causes of secondary hypertension, which we need to keep in our mind? It could be renal, like renal artery stenosis or renal parenchymal disease. It could be coarctation of aorta. It could be adrenal, like pheochromocytoma, primary aldosteronism, Cushing's disease. It could be related to autoimmune disorders like SLE, hyperthyroidism, obstructive sleep apnea, and sometimes drug-induced, like with steroids and other things. Now, looking at the differential diagnosis of chronic hypertension in renal disorders, if there is renal artery stenosis, and the patient usually will have resistant hypertension. On ultra, you can, listen to a renal brew, and on ultrasound of the kidneys, and if you do the Doppler, you might clinch the diagnosis. In renal parenchymal disease, the patients usually are asymptomatic. They are hypertensive, but no other symptoms. There might be a family history of polycystic kidney disease, SLE, or there could be history of, renal failure in these patients. And, the creatinine may be high. And if you do a urine examination, there could be casts in that. There could be proteinuria. And if you do the ultrasound, you can kind of clinch the diagnosis of renal disease. In adrenal disorders, it could be primary aldosteronism, which is usually asymptomatic. There is hypertension, hypokalemia, and imaging of the adrenals would help. And pheochromocytoma, it's quite obvious. Patient has episodic headache, sweating, palpitation, labile hypertension, and you have to do a 24 hours catecholamine or vinyl mandelic acid. And of course, MRI of the abdomen might give you identify that. Cushing's, again, it is quite obvious. Moon faces, central obesity, thin skin, easy bruising, and 24-hour urinary free cortisol and MRI of the adrenals is what is required. Cooptation of aorta is important because here the patient may be again asymptomatic, and it could be hypertension in the arms and low blood pressure in the lower limbs is what will clinch the diagnosis. And there would be radiofemoral delay, and echocardiogram will help you diagnose it. Then, of course, for other autoimmune diseases like SLE, antiphospholipid syndrome, we have various investigations which need to be done based on the history. Hyperthyroidism, you can, again, it's quite obvious. You can always do a thyroid function test. And of course, obstructive sleep apnea, one would know from history and also from associated pathologies like PCOS. So this gives a rough idea. So the crux is that whenever you have a young patient with very high BP, it is important that we have a physician on board who can help us identify these patients. Now, what assessment do we need for to do end organ damage at our end? Now, supposing the patient is essential hypertension, it's a long-standing, we must always do a renal assessment, do a kidney function test, do a urine routine microscopy. We can do a urinary protein creatinine ratio, and of course, ultrasound of the kidney. So that is the basic minimum you can ask for. We must do a cardiac evaluation for all these patients, do a ECG, ask for a echocardiography. That's a basic, right? And of course, in the eyes, we would do a fundus examination. And in case she's got any associated pathology like diabetes or something, we are going to go further and do examinations for that. So some words about management of hypertension. So offer antihypertensive treatment to a pregnant woman who has chronic hypertension if she's sustained BP of more than or equal to 140 millimeter or sustained diastolic of more than or equal to 90 millimeter. The target BP is 135 by 85. Now, we should stop or switch if the patient is on ARBs or ACE inhibitors or diuretics due to increased risk of congenital malformation in the fetus. Diuretics is plus minus, but if she's on ARBs or ACE inhibitors, they have to be stopped. We should also stop the antihypertensives if the patient's systolic blood pressure when she visits us is less than 110 or diastolic is less than 70 or she has symptomatic hypertension. And remember that she needs to be switched over to safer alternatives that are labetalol, methyl-dopa, and nifedipine. Diuretics only if it is a salt-sensitive hypertension. So sometimes diuretics can be continued, but we try and stabilize them on labetalol and then add on nifedipine to it. So next is the last is optimization of modifiable factors. I think that is something we really need to keep in mind and we need to emphasize upon it. We just give up. We say no one listens to us, but I think we should continue and keep finding methods how to impress upon them the importance of these factors. You can talk about epigenetics, you can talk about many things and try and convince. And it can be a family, combined family management, not only, telling the woman to do that. So you can ask the whole family to support her. After all, the baby is going to come to the family. So weight management is most important. And then of course, if there is smoking, cessation of smoking, and then adding regular exercise for the whole family. Let it not be only for the woman. I think that is the only thing which works. And I always tell them it is a triple-legged race. You can't ask a woman to run alone. So please run with her. So, then healthy diet, decrease salt intake in case it is a salt-sensitive pregnancy, and optimal control of other comorbidities. It is best to have her as optimized as possible in whatever way. Right. So that is what we should. And all nutritional deficiencies like folic acid, anemia, and iron, folic acid, vitamin B12. So all those things have to be kind of, emphasized upon. So to conclude, chronic hypertension is defined as hypertension diagnosed or present before pregnancy or at least on 2 occasions before 20 weeks of gestation. Most often it is essential hypertension, but those with severe or resistant hypertension must be investigated for secondary hypertension by a physician. And preconceptual counseling and assessment is important for optimizing maternal-fetal outcomes. It is important that sometimes the patient may not go to a physician, but you should know what you should actually be looking at. So in a well-controlled patient who's hypertensive, initial assessment must include an end organ assessment by urine examination, KFT, ultrasound for kidneys, urine protein creatinine ratio, ECG, echocardiography, fundus examination. Remember to take her blood pressure and keep in mind coarctation of aorta. Patient must be counseled for lifestyle modification. Thank you so much for patient hearing.
Wonderful talk, Dr. Puri. And you highlighted pre-pregnancy is preconception counseling, and that period is so vital, and we can optimize the condition, this condition, comorbidities, look at the drug review. I mean, we're really lucky if patient comes to us, and we can do such a lot for her. So thank you so much for that one.
Thank you, ma'am.
can we-
Wonderful talk as always. Thank you. Very precise.
Thank you.
Meena, please introduce Dr. Girija.
So it's a pleasure to invite Dr. Girija Wagh for the third talk in this session. And she is professor and head of the Department of Obs and Gynae in Pune, Director, Primrose Wellness and Care.
I think, Meena,
And,
that's enough because we are running late.
Sure. We all know, ma'am.
Thank you so much, Meenal, for that wonderful introduction. And also, it has been a treat listening to all the stalwarts speaking. I just want a confirmation whether my screen is being seen.
It started sharing. Yeah. It's coming on.
It's coming on. It's asking me resume or something. Karna hai kya
We
wo?
can't see as of now. It is showing that it has started screen sharing.
Double click.
Can
It's
you
come
see
now.
now?
Yeah, now you can see. Make it into slideshow.
Am I in the slideshow now?
Yes, perfect. Yeah.
He's saying continue to share. What should I do? Continue
Go
to
to
share.
go to continue to share. Yeah.
Okay.
Okay. So
Okay, thank you so much. First and foremost, I must thank Dr. Charmila for giving me this wonderful opportunity. And when Charmila gives opportunity, it is a lot of hard work. You have to read and you have to present in 15 minutes. So likewise, we are going to speak on postnatal HTP today. And what are we going to expect in this talk? Postnatal hypertension definitions and classification, surveillance and monitoring, and some case studies. I'm not going to cover contraception or any interpregnancy optimization because they are entirely two different topics. And it's very important that in the learning objectives, we learn to define and classify postnatal hypertension because it's a new entity which is coming up, and apply effective surveillance strategies in clinical practice and recognize the opportunities for optimizing maternal health between pregnancies. That's very important. So the postpartum period is not the end of care, and it is the beginning of lifelong vigilances. And we have had such wonderful talks from Dr. Prakash Mehta and Dr. Manju Puri and Chinmay, and everything has happened now and the patient has delivered. And we all know the definitions of hypertension are responsible for maternal deaths, and anything which is 140/90 or more during pregnancy is very important. Likewise, intrapartum, postpartum is important because this is definitely associated with an increased risk of persistent postpartum hypertension and long-term cardiovascular disease. So when we define the postnatal hypertension, it is the systolic BP of more than or equal to 140 and a diastolic blood pressure of more than or equal to 90 occurring after delivery, typically within the first 6 weeks postpartum. And why is it important? Because it is a leading cause of maternal morbidity and requires close monitoring, especially in the first 10 days postpartum, and may signal underlying cardiovascular risk. So classification is something which has come up nowadays, and there's something called as a persistent chronic hypertension, where there has been pre-existing or diagnosed before 20 weeks of gestation, which will persist beyond 12 weeks postpartum. There is gestational hypertension, which we all know that it will resolve postpartum and it will resolve within 12 weeks, but it is diagnosed after 20 weeks of gestation. Postpartum new onset hypertension, which develops after delivery, often within 3 to 6 days postpartum, may be transient or evolve into chronic hypertension. And the preeclampsia, eclampsia in postpartum, there can be new or persistent hypertension with proteinuria or organ dysfunction, but it may also present as a de novo postpartum even without any antenatal signs. And therefore, a very, very compassionate, empathic suspicion and surveillance is extremely important. Now, if one looks at the incidence in a systematic review and meta-analysis, the incidence of postpartum hypertension in the first 2 years after HTP was 28.4%. And in a study from Uganda, they reported the prevalence of persistent hypertension at 3 months after delivery among women with HTP about 39%. So whatever hypertension that occurs in the reproductive age, chronic hypertension would be 1 in 13, preeclampsia during pregnancy 1 in 13 to 50, chronic hypertension 1 in 50, and in the postpartum period there can be de novo postpartum hypertension 1 in 8 in some instances, and therefore we have to look at pregnancy as a very wonderful window of opportunity or probably a stress test to identify how the woman's cardiovascular system is going to depend. Now, this is very interesting thing to see the postpartum regulation of blood pressure and BP trajectories. Now, after the delivery of the placenta, there is a withdrawal of the placentally secreted vasodilatory hormones, and there is an increase in the systemic vascular resistance and a rise in blood pressure with a peak systolic blood pressure, which would occurring on days 3 to 5 postpartum, and peak diastolic blood pressure occurring on days 5 to 7 postpartum. So this basic change we have to be aware of, and there can be rapid volume shifts and interstitial fluid mobilization, which would contribute to physiological increases in blood pressure after delivery. And in individuals without HDP, BP should normalize by 2 weeks postpartum, even taking into account all these vascular shifts that we are talking of. Now, this is a wonderful sort of a diagram which has been proposed by Professor Sibai. And what does it tell? That there is an overlap of persistence of pre-existing hypertension, a de novo newly occurring hypertension, and a secondary hypertension. So this postpartum hypertension has a host of potential causes, some of which may be benign, and the persistence of mild gestational hypertension, mild chronic hypertension, whereas others, that is severe, they can be de novo, preeclampsia, eclampsia, or the life-threatening HELP syndrome. So whenever you are seeing this hypertension, it's our duty and important obligation that we try to identify whether any of these causes are there which are responsible for this particular hypertension, and they can be simple innocuous chronic ones, or they can be something which may require immediate attention. We have had patients coming to our center with absolute cerebral strokes where they have been chronic hypertensives, and then they have had a delivery which everything went well, and this was within some 3 to 6 weeks of that delivery. We have had these patients coming to us presenting with stroke or thromboembolic phenomenon, and therefore we have to be carefully looking at this patient. Now, who are these women at risk of postnatal hypertension? Especially the ones who are consuming a very high salt diet, pre-pregnancy obesity, advanced maternal age, and gestational diabetes happen to be the strong predictors of persistent postpartum hypertension in studies. And if you look at the causes and initial evaluation, one has to look for persistent hypertension more than 48 hours postpartum. Common causes, as I told you, gestational hypertension, preeclampsia, chronic hypertension. Evaluation is based on the clinical history and symptoms, blood pressure trends, laboratory evaluations, and response to prior antihypertensives. It's important to avoid aggravating agents, discontinue ergonovin and decongestants, and these may worsen BP or cause cerebral symptoms, and one has to be very careful. Sometimes we find there is an unnecessary usage of these medicines for a long period of time, and they have to be properly taken care of. There are also secondary causes, such as it may arise from lupus, hypothyroidism, HUS, stroke, and cardiomyopathy. And as I said, high index of suspicion is essential when evaluating postpartum women with elevated blood pressure. Monitoring, timely reporting, and prompt evaluation of symptoms are critical, and patient education on warning signs of severe hypertension and preeclampsia is extremely vital. One has to understand that if the persistent hypertension is poorly controlled after delivery, it can lead to severe complications such as stroke, seizures, pulmonary edema, renal failure, and even death. And therefore, clinical vigilance in postpartum hypertension is extremely important. The moment you diagnose this hypertension, look for secondary causes. Monitoring and evaluation has to be a continuous important thing. Patient education is very important, and one has to do everything possible to prevent serious complications. So early detection and intervention can help this. Hypertensive encephalopathy, liver hemorrhage, renal failure, eclampsia, stroke, pulmonary edema, and cardiomyopathy are the complications which we have to be concerned about. Now, this is an important study which has been published, and this is telling us about the postpartum blood pressure variability and heart rate variability in women with preeclampsia. And they have studied in women with superimposed preeclampsia and non-superimposed preeclampsia and compared with normotensive patients. And what was found was there is an autonomic dysregulation which is observed in the postpartum period after preeclampsia and differs between those with and without pre-existing chronic hypertension. So postpartum patients
The
with
slides are not seen.
not seen?
Now,
Some
2 slides.
disturbance here.
Just now.
Not seen?
No.
Android support coming soon, it's writing.
Abhi?
No.
It's visible to me. I can see.
Neha Tandon can see.
Yes, we can't see. मैम आप एक बार stop कीजिए और फिर से slide share कीजिए मैम.
You know, nowadays they are coming up with some very, very intricate and polished kind of settings.
Then how come Neha is alone seeing? That I can't understand.
Now we can see, yeah.
Are you able to see now?
Yeah, now we are
Yes,
seeing.
ma'am. Yes.
But
I'm
I cannot
sorry
see now,
for
ma'am. I cannot
Don't
see
see.
now.
Neha, it's okay. We are seeing.
Now Neha can't see.
No, she can't see. Go into another system. We can see now. Yeah. Majority matters.
Postpartum patients with preeclampsia with and without chronic hypertension had lower heart rate variability compared with normotensive postpartum controls, and higher blood pressure variability was observed only in those with non-superimposed preeclampsia, suggesting that autonomic profile of preeclampsia may differ in patients with chronic hypertension. And these are some very, very important things, because many times I have phone calls coming from my colleagues asking, abhi main antihypertensive medicines kaise revise karu patient ke? And this understanding for this is very important. So timing, risk, and vigilance is important. Most women with gestational hypertension normalize BP within the first week. In contrast, preeclampsia may take longer to resolve and can show a biphasic pattern where there is an initial drop and followed by a rise after days 3 to 6 postpartum. BP monitoring is essential at 72 hours, 1 week postpartum, and it can be hospital service or maybe at home monitoring or clinic visits. And all women, even those normotensive during pregnancy, should be educated on signs of severe hypertension, symptoms of postpartum preeclampsia, and one has to remember that the postpartum onset risk are 25 to 40% of eclampsia cases occur postpartum 2 days to 6 weeks, and 1/3 of HELLP causes may develop postpartum. So we have to keep this patient under surveillance. One of the most common gaps in our care for mothers is the lacuna in a proper postpartum care in this mother. So very important to remember special monitoring with preeclampsia with severe features, because they are at risk of pulmonary edema, severe hypertension exacerbation, and this can be exaggerated by IV fluid overload, epidural oxytocin, and magnesium sulfate that we are using intrapartum, capillary leaks, and renal dysfunction. And this can give rise to very bad edema, which is sometimes quite frightful. And monitoring essentials are fluid balances, where you're looking at the IV intake, urine output weight, respiratory signs, cough, then signs of breathlessness, orthopnea. Use pulse oximetry diligently, chest auscultation, and be very, very, lax of doing prompt in doing chest x-rays, because they can usually click the diagnosis. There shouldn't be any reluctance and resistance because the baby is now out of the mother's body. It's very important to train our staff for these modified early obstetric warning score systems, where we can then teach them when they are supposed to look at everything objectively and immediately report to us. And this is how you can bring in this particular thing in your practice. Now, postpartum edema, I'm sure you can just put it in the chat box if you must have experienced this after 24, 48 hours, and a very frightening sight many a times, patients complaining, sometimes can't walk. If you have experienced this, put it in the chat box, a thumbs up that yes, you have found it quite frightening to see a postpartum edema in HTP mothers. And it is because of pregnancy-related fluid retention. About 6 to 8 liters total body water shifts from the extravascular to intravascular spaces postpartum. And this mobilization of excess fluid contributes to peripheral edema. There is sodium retention from pregnancy. Persistent RAS system activation leads to sodium retention to the tune of 950 mole equivalents, exacerbates extracellular fluid accumulation. There is delayed diuresis, although brisk postpartum diuresis occurs up to 3000 cc per day. Initial sodium and water overload in HTP can delay fluid mobilization, and rise in atrial nitrate peptide post-delivery promotes nitriuresis. However, in HTP, hormonal response may be blunted or inefficient. Abnormal vascular permeability increases fluid leakage into the interstitial space, and slowed return of GFR to normal up to 8 weeks can prolong this edema. So I have been able to, I think, give you loads and loads of justification. Do not ignore this edema. It requires attention. So how do you manage postpartum HTP? The initial management approach is, if the BP is 150 or 100 or more, no symptoms and normal labs, you have to still look at focusing in controlling this BP. Start oral antihypertensives. If it's severe hypertension, then you may have to give her intravenous medications or oral rapid-acting nifedipine, and transition to oral meds to maintain blood pressure less than 150/100. And it's always better to keep it less than 140/90 to avoid complications that I mentioned. And we had a wonderful talk from Dr. Prakash Mehta, who told us all about it. So check blood pressure at least 4 times per day postpartum. If it's chronic hypertension or gestational hypertension identified in pregnancy, BP less than 140/90 without treatment, or blood pressure less than 150/100 milligrams with treatment, no symptoms of preeclampsia. If the answer is yes, discharge with individualized plan for community care. And then if the BP is 160 or 100 more, consider high dependency care and invasive monitoring. Sustained blood pressure of more than 150/100, start or increase antihypertensive drugs. My time is over.
No, we are giving you 1 more minute because you gave an exclusive slide presentation to Neha.
Okay, then I think I will not be able to finish it. What to do?
2 minutes.
Okay, 2 minutes is fine. So we have studied about antihypertensive drugs, but these are now I'm going to just show you the screenshots. These are the pharmacotherapies for postpartum care, and these are working on RIDs. And what are these RIDs? These are the ones which determine the safety of these medications during the lactation. And in accordance, you have to use these medications. I will put this on a screenshot later. And we have to have a very tight control. Most of the organizations are saying so, but I would always believe 135/85 is a good control. Use furosemide diligently in this patient. You can use it 20 milligram, 6 to 24 hours post-delivery, once in a day for 5 days. And that is known to show quite a reduction of antihypertensive medications, need of more antihypertensive medications. And this has been proved through an RCT. So you can very, very confidently use diuretics. And the importance of postpartum follow-up is very, very important, because we require to ensure that they come to us for follow-up. I'm not going into details. Once you are comfortable with their hypertension control and their general symptomatic relief, then you can discharge them and then call them for regular follow-ups. In the postpartum follow-up, it's very important that the early postpartum visit is in 3 to 10 days, ideally 72 hours for high-risk individuals, and look at the BP goal management. And late postpartum visits, 6 weeks to 1 year, consider 6 to 12 weeks, 6 months, 1 year, and then annually. And these patients require to be under closer surveillance, because there are various reasons that have been identified, like these are some experiences. You can see that this is a woman who landed in postpartum edema, and this was identified. She was absolutely normal 20 hours, and suddenly she became, problematic. We didn't know whether it was pulmonary edema. X-ray defined it, and there were lots of other cardiomyopathy, etc. differentials that were there. And when it was gone into quick assessment, it was found that she was not given fluids correctly intrapartum, and that later on went into, when you learned how the fluid changes during the postpartum period, and landed her in pulmonary edema. So it's very important that you are sensitive and manage it correctly. We all are quite well versed with managing pulmonary edema, and I'll not spend time in talking about that. And it requires a team approach. And therefore, it's very, very important that if you have a chronic hypertensive patient or a very severe disease patient, to do a cardiac echography also of the mother. And look at this one more case, which is post-cesarean section, PRIME, which was done for cesarean section for fetal distress, and then it was opened 18 hours later on, and you can see the massive hemorrhage she has inside. So sometimes if you are not vigilant, you may land up in these complications. Now, echocardiogram has been driving a lot of medical care, and these are some publications which you can refer to from the Journal of American College of Cardiology 2021, which has gone and studied long term and found that there are definitely changes in the mother later on, which require to be looked at. And are there any predictors? Even these have been studied in a few studies. And as I mentioned at the outset, there are certain predictors which tell us that these are the ways in which patients can land up in problems. Echocardiography, maternal age, and first trimester mean arterial pressure can guide us in that. And there are, of course, the previous speaker did mention about diet, exercise, and all of these things preventing these particular conditions from getting serious. So I conclude with the key takeaways that postnatal hypertension requires vigilant monitoring and timely intervention. Surveillance is essential for early detection of complications. Interpregnancy care is a vital step towards safe future pregnancies. And postpartum care is not the end, it's the beginning of long-term maternal health planning. And thank you for making me part of this wonderful ICOG certificate course, which is committed to excellence in women's health. Thank you.
Thank you, Girija. Thank you so much.
Breathless.
Thank you, Charmila, for also including me as the chairperson of this wonderful session. Thank you so much, Neha.
Thank you, Meena. Thank you, Sandhya. Thank you so much.
Thank you everyone for such an enriching lectures. Now we move on to our next session on panel discussion on critical care in HTP. I would like to invite the moderators.
Neha, introduce the moderators, please. Neha?
Neha, just
Yes,
keep
ma'am.
it short. The introductions don't spend too much of
Yes,
time.
ma'am.
No need.
Just 2 lines, ma'am. I would
Yeah.
like to invite Professor Dr. Suchitra Pandit, ma'am. Madam is consultant, Department of Obs and Gynae, Surya Hospitals, Mumbai, and has been a chairperson of AICC RCOG. Welcome, ma'am. Next, I would like to invite Dr. Alpesh Gandhi. Sir needs no introduction. Sir has been the past president FOXI. He has been FOXI representative to AOFOG. Welcome, sir. I would request the moderators to please introduce the panelists.
Right, so good evening, everybody, and thank you, Charmila and Dr. Parag and Sarita for allowing us to do this panel. I'd like to invite Professor Dr. Anupama Dave. I'm just sticking to one line for everybody. She's from Indore and has been the president of the ISOPAP Indore Society. Next, please. The next is Dr. Shashi Rekha Rangaraj from JIPMER, Puducherry, and she's also been actively involved in a lot of academic problems, and particularly medical disorders is her favorite. Dr. Priya Vora, who is from Mumbai, Monks Managing Council member for the last 10 years and a Youth Council mentor. Next, please. Dr. Preeti Vyas, who is again from Mumbai, again Monks Managing Committee member and part of the Just Doses Association of India. Next, please. Dr. Kavita Bhatti, professor and HOD of OBGYN at Ludhiana, has been the vice president of Ludhiana OBGYN Society. And welcome, Dr. Bhatti, to this particular panel. Dr. Neha, is Dr. Alpesh there?
Yes, ma'am.
Yes, yes, I am.
So Alpesh, do you want to share the slides?
Yeah, please let me.
So friends, as all of you know that HDP is one of the dreaded problems, because it's a day-to-day issue which we see in our OPDs, and at the same time, the complications are worst, and therefore, the prediction and prevention is very, very essential. So can we have a slideshow, please, Dr. Alpesh?
Yes.
Can we just have a slideshow?
Yeah.
Yeah, thank you. So next, so can you make me the host so I can move the slides, or are you doing it, Alpesh? Okay, you
I will do. Yes.
Okay. So critical care in OBGYN refers to specialized medical care provided to pregnant women or new mothers who are critically ill or experiencing life-threatening complications. And this field combines obstetrics and critical care medicine to manage high-risk pregnancies and its complications. And the acute complications, as all of you all are already aware: eclampsia, CNS complications, acute respiratory failure, HELP syndrome, uteroplacental problems, CVS complications, acute kidney injury, hematological complications, and hepatic complications. And of course, the most dreaded one is the death of the patient, which you don't want to happen. Next, please. So whenever we are talking of a maternal evaluation, you're looking at cardiac, renal, liver, brain, and also the eye. So you're doing a fundoscopy. Next, so with keeping this in mind, I'm going to request Dr. Alpesh to take over the first case. Dr. Alpesh, please.
Thank you, Dr. Suchitra. And with the eminent faculties, a galaxy of faculties, I hope this the whole deliberation will be very interesting. Let us begin with the first clinical case. A 36-year-old woman conceived after IUI. Husband working in Dubai, lives in village, was in antenatal care till 28 weeks with normal investigations and scan. She went to PHC. Her BP was 150 by 92 millimeter of mercury. Tablet nifedipine was started. She returned for checkup directly at 33 weeks from 28 weeks with epigastric pain and pedal edema. Her BP at that time was 178 systolic and 110 diastolic. So what is the probable diagnosis, and has edema has any significance in the diagnosis, role of diagnosis? Anyone can.
So, good evening to all of you, and thank you for inviting me to this excellent panel. The diagnosis is.
Which are the probable diagnoses?
So the diagnosis is she's a case of severe preeclampsia, or we can say preeclampsia with severe features. And as far as edema is concerned, according to recent ACOG guidelines, edema is no longer considered to be taken in the to be thought of in the diagnosis. But at times it is seen that edema is a preceding factor. Initially, women in atypical preeclampsia syndrome may develop edema, and then later on may develop a raised blood pressure. So edema should be considered, although it does not come in the diagnosis. And
you rightly mentioned about the diagnosis and about the role of edema. So which are the investigations should we ask at this situation?
Can I take that question?
Yes, please.
I think at this stage, we will have to evaluate both the mother as well as the fetus. As far as the mother is concerned, I would like to definitely get her the PIH profile or the gestosis profile, as what we call it. So I would definitely want her a CBC, a PT-INR, a LDH, a LFT, creat, uric acid to be checked for sure. I definitely would want to also check the baby. So the fetal growth as well as the Dopplers need to be checked. We need to be sure that the baby's Doppler parameters are fine, because when we are admitting this patient to manage the high blood pressure and to manage the preeclampsia, we will have to take a decision about giving them Betnesol, giving them Maxelf, and whether we need to deliver the patient immediately or we will be able to conserve her for some time will also depend on the blood pressure of the individual and how she behaves with the antihypertensives, but it will also depend upon the condition of the child. So I would definitely want both the parameters to be checked at this stage.
So both the parameters for mother and fetus were advised, and these were we'll see these all findings were normal except proteinuria, and but when she was advised for the admission, she refused as her husband is at Dubai and she was waiting for her husband to come. So what will be your plan of treatment? Because once if she gets admitted, it will be easy for us to monitor, but now she is not admitting and she has refused for admission. What will be your next plan for treatment, and should we advise for Maxel to this patient, and why?
Yeah, I think that's the tricky one, because if we send her home and she lands up convulsing at home, thankfully she doesn't have any premonitory symptoms as per your history that you have said, that she doesn't have any headache or blurring of vision or giddiness. But sometimes these patients can just have an abruption without giving us any warning signs at all. So it will be important that we definitely warn the patient, take the consent so that medico-legally we are safe, then put her on labetalol. Probably in my case, I would think that I would tell the patient, even if you're not getting admitted, at least stay back for 4-5 hours. Let us give the labetalol. Let's see if the blood pressure is coming down. Let's see that a steroid dose is given. We have advised magnesium sulfate for this patient, but if she doesn't get admitted, then it is difficult for us to administer magnesium sulfate. And it will definitely have a role before 34 weeks of pregnancy for improving the fetal outcome, where it will prevent the intracranial hemorrhages also. Ideally, less than 32, everybody should be given. 32 to 34 becomes a gray zone whether to give Maxel for the fetal point of view. But from the maternal point of view, it definitely has a role where we can think of giving her a intercurrent Maxel therapy also. I think
you rightly mentioned about that we should take consent from such patients, because she is exposed to so many complications at home and monitoring is not possible. And Maxel is given for two purposes, as yes, you have mentioned, for the fetal neuroprotector and as well as for the prevention of the convulsions. Then patient was advised for admission. After 1 or 2 days, she came and she was admitted in obstetric HDU. Can we admit such patient on our routine floor or routine place, or should we advise only to advise at obstetric HDU?
In such cases in which the blood pressure is so high,
Yes,
170, 112, we would need, of course, OBS ICU care only. She
So
can be
on-
admitted to HDU, but she may require ICU care also.
Okay. So on admission in HDU, BP was 170, 110, 12, and the rest same. The situation was the same. Labetalol is increased from 100 to 200 and then to 300 milligram BD in the HDU, but BP was not controlled. So is it refractory hypertension? What is refractory
I think
hypertension?
in spite of giving 3 antihypertensive in proper dose, if it does not respond, that means it is refractory hypertension.
So failure to treat the severe hypertension of preeclampsia has been identified as the single most serious failing in the clinical care of women who died because of the complications of preeclampsia. Now, what to do to control hypertension? Because with oral tablets, she is already on labetalol 300 milligram BD and nifedipine. Now, what to do?
Good evening, sir.
Can I
Control
answer?
blood pressure.
Can I
Thank-
answer?
Yes,
Shashi
please.
Rekha. Yes,
Yeah.
please.
Thank you for the opportunity. Thank you, Chamla ma'am. First of all, 170, 110 increase severe hypertension. So overall, just like we saw in Prakash's slides, 170, 112 and 170, more than 170, but it requires admission to HDU or eclampsia if you have the facility for to manage. And she should be started with either IV labetalol or oral nifedipine, like in severe hypertension. So we need to escalate the dose. It doesn't respond within 10 minutes. We don't want the BP to come down immediately to 130/80. As mentioned earlier, the MAP should not be falling to less than more than 25% of that. So give 20 milligram labetalol slowly. And before that, we need to ask her if her chest patient doesn't have, because she's not come back immediately. She's taken 2 days. Fortunately, nothing has happened, but she's potentially high risk candidate to have all the complications. So auscultate her lung saturation, everything is fine, and can give labetalol 20 milligram and see the response 10 to 20 minutes. If BP has not fallen down, then you can increase the dose to 40 milligram under careful monitoring after ruling out the contraindications for labetalol. And we can go maximum up to 80. If they're not
So
responding
here
to
the
80,
dose.
then
So here the
The
dose
range-
of IV labetalol was up to 80 milligram bolus was given, 20, 20, then 40, 40 up to 80, but blood pressure was not controlled. So can we give nifedipine sublingual in such cases?
No, sublingual
no.
nifedipine is absolutely gone.
And
Yes, ma'am. Yes.
why it is now not recommended sublingual nifedipine? Any?
So it can cause sudden hypotension and can aggravate a myocardial infarction. So never to give nifedipine, but it can be given orally.
So
And
it can affect
suppose the
both
patient
mother
is
as well
not
as
conscious.
fetus. Yes.
It
And
can
is there
actually
any?
take the blood away from the fetus.
Yeah. So it can affect
The mother
both
as
mother
well
as
as
well
the
as
fetus.
fetus. And we already discussed the role of Maxalp. Yes, Maxalp is to be given to prevent convulsions and is not recommended solely as an antihypertensive. And monitoring of mother for the when Maxalp patient is on Maxalp, respiratory rate, knee jerk, urine output is essential, and we should also have antidote available with us when she is on Maxalp. So patient was advised and counseled for early delivery. The patient wanted her husband to come from Dubai. Meanwhile, labetalol, nifedipine, daily fetal monitoring was continued. Steroid was given as already we had discussed. After 24 hours, her husband came, and then consent for LSCS was taken and LSCS was performed. Then she delivered a female baby of 1.9 kgs and to NICU care. Cesarean section was uneventful. BP after delivery in range of 160 to 170 systolic, 100 to 110 millimeter mercury. Diastolic patient was kept on labetalol and nifedipine retard with IV fluids and antibiotic regime. After 24 hours post cesarean section, she had sudden severe cough, breathlessness, and restlessness. Pulse
So
was
it is
150
like
per minute, BP 200 by 180. Oxygen saturation was 75%. Injection labetalol 20 milligram was given. Oxygen was started. After 10 minutes, again BP was same and oxygen saturation was 50 deteriorated to 55%. On examination, there was wheezing on chest and breath sounds harsh. What may be the cause and what has happened to this patient?
So can I take this?
Yes,
So
please.
this probably has gone into a pulmonary edema because there's desaturation. There are RALs on wheezing and harsh sounds. So basically, many
Yes.
cases of preeclampsia, there could be an overload when you give the fluids very rapidly. And they can even have, as a complication, pulmonary edema. You need to give oxygen, propped up position, restrict the fluid, and you can give 20 milligram Lasix intravenously 6 hourly to reduce, to increase the diuresis. And that helps to relieve the edema in the lungs, even positive pressure ventilation, and an ICU management may be required even in these cases.
And she may be given
So it's a very frequent, we can say,
nitroglycerin.
complication of preeclampsia. And you rightly mentioned the management of the condition, that this is pulmonary edema and what to do. You rightly mentioned.
Can I add
Help was
something?
called, mask oxygen was started, proper position given, labetalol given, anesthetics were called, ECG, X-ray, and 2D echocardiography done, as just Dr. Girija has mentioned about the importance of X-ray, pulmonary X-ray. After 5 minutes, pulse was not recordable, oxygen saturation 35%. Patient was intubated. Furosemide was given as a bolus. Decision to shift the patient to ICU was done. Yes, already we had discussed that such patients may require ICU admission. Immediately on reaching ICU, patient developed cardiac arrest. CPR started, put on ventilator, revived within 10 minutes. Now our BP was 85 millimeter of mercury. Oxygen saturation improved up to 90%. After 1 hour, patient had spontaneous respiration. Now our BP 100 by 64. Yet she was confused. On relatives' wish, patient was transferred to government hospital for further care. So what had wrong in this patient?
Can I answer?
Yes.
So, such a high, we know that it is a flash pulmonary edema representation, and BP is so high, IV labetalol is not the choice of antihypertensive. The ATG, nitroglycerin infusion, is the wonderful antihypertensive to give at that point of time. So that can be sometimes fatal. Giving labetalol with the BP of so much, especially when there is pulmonary edema, that could be fatal. So ATG infusion would have been the ideal antihypertensive.
So it's a leaky vessel syndrome. 70% of pulmonary edema occurs in postpartum period, as just Dr. Girija has described. fluid overload is very, very important. We should be very much cautious about this. Pre-hydration for regional anesthesia is a routine practice at many places, but in such patients, we should be very much precautious. It should not cross 60 to 80 ml per hour. Uncontrolled severe hypertension for a long reason may be also one of the reason for pulmonary edema in this patient, and waiting for her husband to come or prolonged myself also can cause pulmonary edema. So this all can be maybe the responsible factor in this patient. So ideally, she should be admitted earlier. She should not wait for her husband to come. She should be delivered earlier, and one should be very much precautious while giving fluid. It should not be fluid overloaded. And of course, either it should be 60 to 80 ml per hour or 1 ml per kg per hour of current body weight. Remember, this is a very important message. Remember, deaths occur not because of transient renal impairment, but due to fluid overload. If pulmonary edema can occur, if occurs, then death can occur. So it is transient renal impairment is of course a problem, a complication, serious complication, but it is not so serious complication that a patient died because of the pulmonary edema. So thank you very
So
much.
here, can we mention that labetalol should not have been given, especially with a hypertensive crisis in a patient with pulmonary edema? In a patient who develops pulmonary edema with hypertensive crisis, labetalol should be avoided.
Yeah, that is, but once it is developed, before that we were not knowing that this complication will occur.
Sir, one more point. If the patient wants to wait for 2-3 days, probably she needs thorough counseling. Even the family needs to be counseled because they may not be aware of the complications of preeclampsia and so on.
Everything was done. Patients relative were counseled, but patient was very stubborn, and consent was also taken. And let me thank Dr. Girja that this patient was managed by Dr. Girja. This is her case I've collected from Dr. Girja ward. Already everything counseling was done, consent was taken, but patient was not ready.
Sir, in the beginning, you had mentioned also about patient having epigastric pain. So that also needs to be addressed, as in was there any?
Yeah, that also will need to be addressed, but in this case, this was just gastritis, and will going to the next case, which will definitely where we are going to
Okay, sir.
address such problem. So coming to the second case, I think Dr. Suchitra, please discuss the second.
Yeah, thank you, Alpesh. Just before we go on, I just wanted to mention that now we have even nicardipine for a hypertensive crisis. So nicardipine is available as an IV drug. Previously, only cardiologists had it. Now we also have it. It is available as a 10 ml ampule, which contains 25 milligrams. You can dilute it in 240 ml of normal saline. So the rate of the drip is 0.1 milligram per ml, and you can give it at 5 milligrams per hour. So that also helps the BP to come down. Same family as nifedipine, only advantage is it can be given IV also. So we'll move on to the second case. This is a 31-year-old Gravida 3 para 1 with 2 miscarriages at 34 weeks of gestation, seen in the antenatal clinic with vomiting, BP 130/90, no proteinuria, hemoglobin is 8.5, SGOT 60, SGPT 76, and the LDH levels are 620. What is your probable diagnosis? We'll start off with Priya Vora.
So in this case, madam, there is a drop in the platelet count. The liver enzymes have been raised, and it could be where a hepatic involvement is there in a case of, but madam, your blood pressure you all have written as normal, almost just 130/90.
Yes. So what do you think could it be?
So some liver involvement has to be suspected in this patient.
Okay.
It may just also be, madam, a case of maybe thrombocytopenia or more like an ITP case. Because the BP is not so high, but the platelet is not really matching with the blood pressure.
What about the LDH levels? Does LDH tell you anything? LDH,
so LDH is also elevated here.
Yes.
Yeah.
So
LDH will indicate
anything?
hemolysis.
Yeah.
It is more
Yes.
than
So
600. So it will
Yes.
indicate hemolysis.
Hemolysis.
So
Whether
I
she's
think I
going
will
for
go
a
with
Could be
the
help
It could be a
syndrome.
case of HELP
Help.
syndrome.
Yes, but
Help.
you're right, the
Yeah.
differential could be a hepatic involvement, definitely. Let's move to the next slide.
In this case, 130/90 BP is there, but her baseline BP could have been quite less.
Much more
A
lesser.
rise in BP 30 mm systolic and rise in
Absolutely.
20 mm diastolic could be labeled as preeclampsia.
Yeah, let's just move to the next, please. Next slide.
In
Alpesh, you
all
want
the
to conclude?
cases of HELP syndrome, it is not necessary. BP is
Yeah.
always more, but
Yeah.
in at least in 10 to 15% of cases, we may come across HELP
A
syndrome
normal,
even with the
normal
BP.
At a lower
Yeah.
blood pressure.
So this
Mostly
particular
HELP.
patient is HELP syndrome. It's obviously all of you all know what it is. Incidence is 0.2 to 0.6 and 5 to 7% of all pregnancies. And basically, can anyone enumerate? Is Kavita there? Kavita can talk about it.
Yes, yes.
Yes,
I'm there.
Kavita, what are the features of HELP syndrome?
Actually, HELP syndrome will have hemolysis, elevated liver enzymes, and low platelet counts.
Right,
And
right,
it can be classified according to the Tennessee classification or Mississippi classification.
right.
So
Okay.
basically, the platelets will be less than 1 lakh and elevated
Yes.
liver enzymes more than the normal, that is more than 40 international units. LDH can be high.
Yes.
And hemolysis also in the blood film, like you can see schistocytes, Burr cells, and some other hemolytic features can be seen in the peripheral blood film also.
Right.
So basically, these three
Typically, in
characters
this
are
case,
there.
the clinical presentation is quite vague sometimes, but it's just the very high degree of suspicion. As all the three previous panelists said, that it could be a liver involvement, but typically when that epigastric pain, nausea, headache, increased blood pressure, as Dr. Alpesh very rightly pointed out, may not always be there. Proteinuria most of the time is there, but sometimes you may not have, as we know, as per the definition, you need not always have proteinuria to have multi-organ complications, and there may be edema. Next, please. We can, what is the differential diagnosis, what you would entertain? Anupama, Preeti, you can take this up. First, Anupama, take up the differential diagnosis, please.
Differential diagnosis could be TTP or hemolytic uremic syndrome.
Right. And what investigations will what will you do, Preeti Vyas? What will you do to confirm the diagnosis?
So I think this thing that we also need to definitely do is look at the hematocrit.
Yes.
Usually, if it is a liver issue, the SGOT, SGPT would be much, much higher.
Correct.
The values were not very high. So it would go more in favor of not a liver thing. As far as
Correct.
TTP is concerned, usually we do have other history, or a family history also is usually positive for a TTP.
Yes.
Usually we also see on the peripheral smear some abnormalities when there is a thrombocytopenic purpura, and most of the times these patients give a very classical history, with a TTP is there. I think this would definitely go more in favor of a HELP syndrome where the LDH is rising, the platelets are falling, SGOT, SGPT is just mildly raised.
Would you like to do a sonography at all over here?
Definitely.
If possible, if
Def-
access is there, because you can check out for the liver areas, you can check for the intraperitoneal hemorrhages, and of course, LDH, we look at a LDH is a very important, even a rising LDH levels more than 300 can suggest a partial HELP, but obviously when it's crossing 600, it's indicative of a complete full-blown HELP syndrome. Next, please.
Full-blown HELP.
Next, Alpesh, next, please.
Can I say one?
Yeah, please.
Yeah. So in depression diagnosis, basically there are 3-4 conditions. We can say TTP, HUS, HELP syndrome. In HELP syndrome, more or less hepatic factors will be more positive. In all these three, all such factors are there, but liver is more involved in HELP syndrome. In HUS, renal, kidney is more involved, and in TTP, neurogenic factors are more involved, and there can be thrombocytopenia and coagulopathy in TT.
Yeah. Can we go on to the next? Yeah, so when we're talking about a management, obviously it has to be a little aggressive management. So Priya Vora, what is the
Yes, madam.
specific management for a HELP syndrome, and does it have any
I think-
particular maternal and neonatal implications?
So, madam, in patients of HELP syndrome, you have to first of all stabilize the patient, and these are patients of high risk, so they should be an ICU setup. And as usual, the airway, breathing, circulation, all that needs to be looked into also. And these need aggressive monitoring, like you have to maybe twice in a day, you need to monitor the LDH, the platelet count and all. And you have to control the blood pressure with antihypertensive intravenous labetalol and all that. You have to give steroid for the lung maturation, and Maxulf also should be given to either the Pritchard's regime and all to prevent a seizure. And these patients should be stabilized and they should be delivered quickly. Because they can there can be deterioration of the fetal and the maternal condition also. So you need to deliver, and there could be always a lot of bleeding in these patients. So whenever there is a thrombocytopenia, when the platelet count is less than 50,000, you need to keep blood and blood products ready. Even platelet transfusions may be required in these patients.
So what will be your point of deciding when exactly to deliver? Will it be the platelet count? Will it be the fetal condition? Will it be the maternal condition? What is your exact, okay, now I need to deliver this patient?
Her maternal condition. So once we have identified that help has occurred, then please quick delivery. That only can save the mother. And one point I would like to mention that it has been said that steroids can be given temporarily. They help in immediate management, but long-term delivery is the only way to treat her.
Absolutely. So are there any cases where you would wait on a help, or would you prefer to deliver? Does the period of gestation matter? And the maternal general condition, does it matter at all?
Irrespective of gestational age,
we have to
deliver. Madam, most guidelines say that if it is more than 34 weeks, you have to deliver. And even if the gestational age is less, because of the rapid deterioration in the mother and the baby, it's always better to deliver, because these patients can have a lot of issues.
Absolutely.
I think, ma'am, one more thing I would like to mention is sometimes these patients, because the low platelet, we prefer not giving them intramuscular injections. So they're better off with a Zuspan regime rather than a Pritchard's regime in these patients for Maxulf.
Yes, absolutely. Now, supposing you've decided this patient is in a tertiary care center. You have got your blood products ready, your hematologist is involved, your anesthetist you've called, and you now have to deliver this patient. What would be your criteria? Would you prefer a regional? Would it depend on the platelet count, or would you just straight away go in for a C-section, for a GA?
Yes.
I think it will depend upon the platelet count.
Vaginal delivery is preferable, but if in case cesarean is required, then we'll have to see the platelet count. So the cutoff which we take for platelet count is 50,000. And regional anesthesia can be given if it is more than 50,000, but preferably general anesthesia in such cases.
Yeah. So
And,
generally, I think above 50 and 75, actually, anesthetists are comfortable if it is 75. Because between 50 and 70, they're always still worried about the little hematoma. And what are the precautions for a C-section? This is a particular C-section which should have ABC precautions. Any one of you, Anupama?
So we need blood products ready. And at the time of cesarean section, we need to monitor her blood pressure. If blood pressure could be a bit low, and then after it, she could start bleeding. And this is the reason why an intraperitoneal drain should always be kept.
Yes, yes. And importantly, these are the sections which should not be done by the very junior people. It should be done by, because it should be done preferably as soon as possible. There is always a great risk of the rectus sheath hematoma drains also, rectus muscle drains also, because the platelet counts fall too much more lower. And this patient has to be very vigilantly monitored. Are you worried about postpartum help again? She's controlled now. Do you think that can happen again?
So we need to reserve blood and blood components also before we proceed for section, ma'am.
Yes, absolutely.
Also, we use electrical cartridge because there could be small bleeding which can cause. And drain has to be placed. Subrectal drain as well as peritoneal drain has to be placed.
Yes, and here when you find that the platelet counts are falling down, you probably need to give a little more longer duration of steroid therapy. Because then once the platelet starts stabilizing and start rising, then you know the patient is out of the woods. But otherwise, these patients need to be very, very carefully monitored. So usually we just wanted to mention that generally 34 weeks and above, as you all rightly agree, deliver immediately between 27 to 34 weeks. Obviously, you cannot sit on a help, but stabilize them, get all your blood products ready. If you're not in a tertiary care, transfer them, give them the steroids, give them the Maxelf as required, and shift them to the tertiary care center. And conservative management, not more than 48 to 70, even 72 hours, we would be very, very careful because it can suddenly deteriorate. And obviously monitoring, very important. And most of the time, if you're worried about a postpartum health, you are concerned about a pulmonary edema and the risk of renal failure. So therefore, fluid management, very rightly, as you all have discussed earlier, very judicious. And risk of renal failure, how would you prevent that risk of renal failure? What is your monitoring strategies in the post-delivery period? Preeti?
I think we need to monitor the urine output for sure. So we don't want an over infusion of IV fluids, but at the same time, not an under infusion. Make sure that at least 30 to 50 ml per hour is a urine output that is being
Yes.
coming, and vigilant monitoring is the most important.
Auscultation of the lung basis.
Right.
Absolutely.
Right. So
And the renal parameters, please keep checking the renal parameters. How frequently would you repeat the patient?
especially if the magnesium sulfate has been given, then all the more reason that we need to keep a watch on the urine output.
Yes.
And sometimes we also need to remember, a lot of these times, these patients who had come also with preterm, if they have been transferred from another center to a tertiary care, they may have already given them some utero relaxants. So these
Yes.
are the patients who would in fact be even at more higher risk of having a pulmonary edema, and even a small
Absolutely.
bolus of IV fluid as low as 500 ml, which is given intra, can sometimes push them. So we have to
Absolutely.
be careful.
Absolutely. So that's why it's very important for all the listeners. Whenever you're transferring a patient from a primary care center to a tertiary care, please list all the medicines and all the fluids that you've given. So it helps the person at the tertiary care to manage. And these are typical problems. These are the patients whom we have to be vigilant because you don't want a maternal morbidity. Alpesh, can we move to the next slide, please?
Yes, so this is the last slide for the HELLP syndrome, and all such cases should be monitored in obstetric HDU, admitted in obstetric HDU or tertiary care center. And Dr. Suchitra, we are well in time, and in 30 minutes already we discussed 2 cases.
Yeah.
So
Just Alpesh, just one last line which I would like to say. For a help, supposing
Yeah,
you're
you can
finding
also
that
take this in next
Yeah.
5-7 minutes, 10 minutes.
Yeah. So when the platelet count is falling and the LDH is not yet risen to 600, please keep these patients under vigilance. I would admit those patients because in the next 24 hours that LDH level can suddenly go high. So check out, maybe the BP is being missed, maybe something is being missed. So vigilantly check these patients. Okay, so we'll move to the next
Yeah,
case.
so if in next postpartum in next 72 hours,
these are
it
all
is
cases
not
which
improved, then also think for TTP. Then always think for TTP. There is a
Yes.
strong possibility of TTP, which is not improved in 72 hours. So,
Ma'am, can I add one line?
continue,
Yes,
Dr.
please,
Suchitra, for please.
In this HELLP syndrome, one should always remember that APTT will not be deranged.
100% right.
Yes.
Very,
Yeah.
very correct point you brought out. APTT will not be deranged. Absolutely right.
Yes.
Very right. So this is a third case. This is again a real case, the posterior, the press syndrome as we call. So in this particular case, next please. This patient had come into the emergency. She was 32 years old, 34 plus 3 weeks with a DCDA twin. She had just been seen in the hospital 5 days ago, but her husband called up saying that she's convulsing. So he brought her. Luckily, they were staying very close to the hospital. Within 20 minutes, he brought her, and he said she had been having history of headaches, but the headaches has been her feature for the last 6 months. So in this particular case, he says in the last 3 to 4 weeks, it would suddenly go very high. She used to have a lot of acidity and she was not able to sleep well. The moment she slept well or some antacids were taken, her headache would go away. Her BP monitoring her husband was doing, and they used to keep calibrating. BP has always been normal. When we saw her, she was conscious, responding to verbal commands, but she was disoriented. Pulse was 100, BP was 160 by 100. Uterus had an increased tone without relaxation, and there was tenderness. Next slide. This was a DCDA twin, but only one fetal heart could be heard. So if the Maxel was kept ready, given immediately, levetiracetam was also given, labetalol was given, and because the uterus was feeling hard and not relaxing with a suspected abruption, the patient was immediately shifted to the emergency, from the emergency to the theater. And during the section, there was a retroplacental clot. The babies both were delivered, one male, one female, and they were transferred to the NICU. Next, please. There wasn't any atonic PPH. Uterus in fact contracted very well. We were very worried about that. Now, just to give you a quick recap about the past history: short stature with the high BMI. She was 33 BMI. Metformin and folic acid was started preconceptionally. Because of the low AMH and irregular cycles, she did not respond to the first two ovulation induction, but the third ovulation induction, an IUI was done and she conceived. Her gestosis score was 10, so ecosprin was started right after conception. But after the nuchal scan dual marker, the fetal medicine team stepped up the ecosprin to 150, and the patient off and on had severe acidity and constipation, headaches. Physician and a neurological as well as an ophthalmological consultation was taken, and they all said that she was extremely stressed out and having a lot of acidity. Sugars were normal. HbA1c was on the higher side, but she was already on a diabetic diet. There was no proteinuria and BP was always in the normal range. Next, please. The patient after the C-section was shifted to the ICU for observation in the post-op period, had one more convulsion despite the Maxel. So neurological consultation was taken, and MRI brain suggested a Press syndrome. So any of the panelists, what is the management of a Press syndrome?
Cannot exist.
The first thing to be done, ma'am, is stabilize this patient. It is basically a neurogenic syndrome, and there is usually a lot of edema especially in the parieto-occipital lobes,
Correct.
So first thing, put them in an HD or an ICU facility. You have to control the blood pressure, and then you have to control the seizures. Both are extremely important. Press can be quite dangerous because, if not well managed, it can even result in mortality. So it is definitely the job of an intensivist that we need to look at, when we are managing.
Let me just put on the next slide. Yeah. Preeti, go on. Yeah.
Yeah. So these patients definitely require mannitol for reducing the brain edema. There is to be a multidisciplinary approach. We have to get the blood pressure down either with labetalol or with nicardipine or this thing. If the seizures are not under control, give seizure medication like what you mentioned, levetiracetam. DEXA is usually required for these patients because of the edema to be reduced. And our idea should be to reduce the blood pressure by 20 to 25% and not have a sudden drop of blood pressure, because a sudden drop of blood pressure can also result in can also be detrimental to this patient. Have to keep these patients usually for minimum 1 week, even after they look fine, because their risk of throwing a thrombus is also as high in these patients. And we do see these not only in preeclampsia and eclampsia, we also see this kind of conditions with a hemolytic uremic syndrome or with a TTP or with patients who are on certain immunosuppressive type of drugs. And also we definitely need to keep a strict watch on them.
So, the role of mannitol is controversial. So there is one group which says don't give, the other group says give. But in this case, we have given and we found that it was useful. Afterwards, we reduced the dose. Why do you think it should not be given, Preeti or Priya or anyone who wants to?
There are chances with a raised blood pressure, there are chances of cerebral hemorrhage, subarachnoid hemorrhage. And these cases we cannot give, but if she's had an MRI done and if Press syndrome is identified, then definitely
Yes, because then once you've identified it, it is actually helping the levetiracetam as well as the Maxel in reducing the seizures by reducing the edema. But if you don't know it is a Press, then in those cases you should avoid giving mannitol till you have a definitive diagnosis. Next, please. So when this patient was discharged, she was discharged on antihypertensives as well as antiepileptics. So how long would you give the levetiracetam? How long should you be giving it for?
Madam, I had a similar patient where the physician advised to give levetiracetam orally 500 BID for almost 2 weeks. And
Yes.
even the antihypertensives, you need to give much longer in these patients. You should not
Yes.
quickly try to taper off. At least 2
Yeah.
weeks they were giving it.
14 days.
Yeah, so in fact, in this case, they advised it for 3 months. 500 initially they were giving 3 times, and they reduced it to 2 times, and they said continue it for 3 months. And the patient was coming for a regular follow-up. Surprisingly, now a year later, she's lost a lot of weight. Her BP is fairly stable. She was put on amlodipine later on, but after about I think 7-8 months, the BP started coming back to normal. She's lost almost 10 kgs. So I think this made a lot of difference. So the causes of PRES, obviously, we know eclampsia and we know about the hereditary form mole. But one must remember that this could be drug induced also, and some kind of a systemic inflammatory response can also cause it, and even a hypomagnesemia would be able to cause it. Next, please. So the important thing is, if you have an MRI, it's always much more better, because you can quickly, every hospital will not be having an MRI, but in this case, what is recommended is stabilize the patient, and then if possible, get an MRI done, because then, clear cut, what exactly have to be given. Do you think that the patient who's had a PRES, when she conceives again, she has a strong chance of getting a PRES again? Is there a recurrence rate, high recurrence rate, Dr. Anupama?
Yes, yes, ma'am. In next pregnancy also, she's likely to have PRES syndrome. It is because of her cerebral edema which occurs in these cases.
Yes.
I would tell the patient, if you had a good baby, then sit down quietly.
Absolutely. Now, in this case, of course, she's had 2, so she doesn't want to, but we must give them that, post discharge counseling for contraception, for lifestyle changes, weight reduction, monitoring of BP. And if they want to conceive, they must know what the risks are. They must come to a doctor before. So let's go to the next slide. And Alpesh, so PRES, obviously we've discussed all this, and PRES is completely, the beauty is it's completely reversible, but they need to be on, very, very regular follow-up. And as I said, anti-epileptic drugs for 3 months. Next, Alpesh, you want to just summarize now?
There are
Alpesh, take
patients who are conceived. I mean, there are increases of preeclampsia, not necessarily PRES. But
yes, absolutely.
If at all she conceives again, you have to start aspirin and have careful monitoring.
But
Not
she
that
must,
pregnancy is absolutely
absolutely
contraindicated.
right. She must be counseled about the risks, and she should be vigilant enough to come for a follow-up. And we also have to, know that. Next, please. So Alpesh, you want to summarize it?
I think we could complete discussion of 3 important cases, and only 2-3 minutes are left, so we'll not go for the 4th case. And I think at the end we should always remember that hypertension disorder in pregnancy, particularly preeclampsia, severe preeclampsia, is a very serious pregnancy complication. It is a multisystemic problem. It and if we look
Alpesh,
at
change the slide, na? Change the slide.
No, it's a end of.
Okay.
You can stop sharing, sir.
So the
You can stop sharing.
it is number 1. It is number 1 indication for the admission in obstetric HDU, and PPH is not number 1 indication, and it is number 2 direct cause of maternal mortality. So we should always be very much watchful. Screening is very, very important. Early diagnosis is very, very important. Early intervention is very important. Counseling is very important. Close monitoring of mother as well as fetus is very important. We need to admit such patient in tertiary care center or obstetric HDU. This is very, very important, and we should always keep our setup and our staff ready to manage all such difficult situation and complications. Thank you very much, Dr. Parag, Dr. Savita, Dr. Charmila, for giving us opportunity for to discuss this important panel discussion. And I think let us give big applause to all the panelists for a wonderful role. They all were very brief, very specific. That is why we could complete 3 cases in just 42 minutes. So it's a very good.
Good thing. And please don't forget,
very
all
much.
the
Thank you.
listeners, please use Justosis score. use it day in and day out and use it. It's a dynamic score. Use it at the first visit, at the second visit, at the third visit. First visits, you know the intervention. The second visits also, you know how to monitor. And the third visit can tell you what is the seriousness of the situation. So if you want to refer her to a tertiary care, you want to monitor her more vigilantly, you want to do the S-split by PLGF ratio, you know how to intervene. Use that Justosis score as a friendly tool. It's very, very simple to use, and Gorak has got that link now. So even if you press on the
And
link,
this
you
score
get the
is
entire score.
now, and this score is now already made mandatory by the government of two states, Tamil Nadu and
Yes,
Karnataka,
and
and lots
Karnataka.
of studies are now available about the role of this Justosis score. And if you look at there are two methods for the screening. One is the combination of maternal high risk factor, maternal arterial blood pressure, and uterine artery PI and biomarker. On one side, there is a combination of all these four parameters, and on the other side, this is simple Justosis score, which is it is not at all costly. And if you look at in both the screening tools, the success rate is in 80% of the cases we are able to predict possibility of HDP. So you can very easily practice Justosis score in your practice. Thank you very much.
Thank you very much, Suchitra Pandit Madam and Dr. Alpesh. Two stalwarts doing a panel on critical care is a great credit to the work certificate course. Thank you so much for your inputs. I'd like to thank all the expert panelists, Dr. Anupama, Dr. Sasreka, Dr. Priya Vora, Dr. Preeti Vyas, and Dr. Kavita Bhatti. Thank you so much for joining and for those wonderful inputs. We'll go on to the assessment questions
Next time,
now.
please give us 1 hour.
Sir, that is Parag's prerogative.
Because we are literally racing.
Can we have the assessment questions, please, and the timer?
Suchitra, we need to be really fast.
We were in marathon.
You don't have time to think, to talk to panelists at that time. So you really have to be very, very quick. Thank you so much, both of you.
Thank you.
Can you give the link now? On the link is there. And put the timer on, Shreya. The link is there. Please start. The timer is also there. You get 15 minutes.
Charmila, before you
Yeah.
announce the answers,
Ah.
I would like to appreciate the efforts put in by yourself and Neha for completing the first day successfully. Sitting here for 3 hours, being attentive, answering to all the chats is not an easy task. So thank you very much for doing so wonderfully well. And thank you all the faculty. Thank you all the delegates who have stayed back. It was heartening to see the figure crossing 550 at one time. So thank you very much, and I'll see you again tomorrow on the second day with hyperglycemia in pregnancy. Thank you.
Thank you.
Thank you,
Hey,
Parag. Thank you so
Parag, it
much.
was, yeah, just Charmila, it was excellent. Everybody really did a excellent job today.
Thank you, madam.
Certain topics I really feel, that we really need to give more time. We will think about it more focused later on because
ma'am.
it was really very, very useful. And right now, our problem all over the country is hypertension.
Yes, ma'am.
Yeah.
Thank you so much.
Sheila probably will have one 3-day course on hypertensive disorders.
Yes, yes, Parag, I fully agree with you. And we should do it every year, in fact,
Yes, yes.
Yeah.
Sure. Thank you, Sheila.
Yeah. Thank you, Parag, for the opportunity. Thank you so much. Like to thank Neha.
Thank you,
Wonderful
ma'am.
job. It was so like you did it like a professional and everything. It was so good. Thank you so much.
Thank you so much for the
Wonderful
opportunity,
work.
ma'am. Thank you,
Wonderful.
sir.
Yeah, wonderful work. Like we'll just have the yes, Shreya has already shared. So the answer is the drug which is used for inhibiting platelet aggregation. I think Gorak was very clear on that, aspirin. The dose, it will reduce the incidence of risk of hypertensive disorders by almost 60 to 70%. And what is the dose recommended by the WHO and NHM India? It is 75 milligram. Shreya, can you go up? Yeah. And antihypertensives are indicated. Now you have to start it as early as 6 to 8 weeks. Antihypertensives are indicated when the blood pressure readings of 140/90. And a lady in a second trimester with gestational hypertension, the first line agent is labetalol. And which class is contraindicated throughout pregnancy due to teratogenesis are the ACE inhibitors. Next. Primary goal of fetal surveillance is to identify fetal compromise and timely delivery and at an appropriate time and place. And which of the following fetal monitoring tools is most predictive of imminent fetal acidemia as ductus venosus Doppler, and the modified biophysical profile includes which of the following? It is fetal NST and the amniotic fluid index. And in HTP, which Doppler findings suggest fetal compromise due to placental insufficiency, it is absent or reversed end diastolic flow in the umbilical artery. And for women with preeclampsia, what is the minimum recommended duration for postpartum blood pressure monitoring is at least 72 hours postpartum. And which antihypertensive agent is avoided postpartum due to accumulation breast milk and potential neonatal adverse effects is atenolol. Next, please. And postpartum period, antihypertensive therapy is initiated when blood pressures are more than 140/90. And women with preeclampsia and 6 weeks postpartum and still has persistent hypertension and proteinuria, she will need a refer for a chronic hypertensive workup or a renal disease. What is the primary biological role of PLGF in pregnancy? It promotes trophoblastic invasion and angiogenesis. Which statement best describes the significance of the ratio of SFLT PLGF in preeclampsia prediction? A high ratio indicates a prior placental, actually a poor placental perfusion and a higher risk of preeclampsia. And according to the prognosis study, which is a ratio which will give a high negative predictive value to rule out preeclampsia within 1 week, that will be 838. Which of the following best explains why SFLT1 levels are elevated in preeclampsia? It is placental hypoxia induced overexpression of anti-angiogenic factors. Which of the following drugs is not contraindicated in a patient with chronic hypertension planning a pregnancy are the calcium channel blockers. That is over. Yeah. Thank you so much for joining, and tomorrow we'll join back for hyperglycemia and pregnancy. I'd like to thank all of you, and the score has been put up by Vidya Dobi madam. Please, you can open that link and get into that. Thank you so much.